Yeah, we're live now, just about now. I thought we could just start, or what do you think? Dr. B, are you there?
Yes, I am here.
So that
Can you
we
hear
keep
me?
to time, I think we should start.
Yes, I agree with you. So, good morning, everyone. It's a beautiful Saturday where I am, and I'm guessing it's a beautiful Saturday where you are too. Welcome to this Autism Awareness webinar organized by the C.A.D.E.T Academy. It's in recognition of this year's Autism Awareness Month. And today we're going to be talking about understanding the multidisciplinary approach towards autism spectrum disorder in an inclusive school. So a few things that I'll go through before we get started. Please ensure that your microphones are muted. That's just to avoid any distractions. You can keep your videos on. Would love to see your faces, would like to engage with you. But if for any reason you don't feel comfortable having your videos on, by all means, please turn your video off. Wherever you are, I understand that, we all might not have quiet spaces. I personally don't have one, but just be mindful of the background noise. If you're speaking and your background is noisy, do be mindful of the background noise. And with this webinar, I just want to say, whatever you put in, the energy you put in is what you're going to get out. The people who have come here today have come to pour into us. So if you come with a spoon, you take away just a spoonful. If you come with a bucket, you take away a bucketful. So I'm asking you, come with all your energy, come to be impacted, come to engage, come to, participate, come to draw on all of the insight and knowledge that's going to be shared here today. So that's just everything in terms of housekeeping. I am going to give you a quick rundown of how the program would go. First, we're going to have the opening remarks by the host, and then it'll be followed by the speaking sessions. Each speaking session would last 20 minutes. And after that, we'll have a question and answer / reflection session for about 10 minutes. It's just to go over what we have just heard and just discuss. You might have something to say. It doesn't necessarily have to be a question. It could just be a comment. What has been said might, strike a particular chord in you, so you want to talk about it. We have about 10 minutes to do that after each session. Then after all 3 sessions are done, we'd have a 5 minutes sort of break where a video is going to be played. You can also use the period to, take a quick restroom break. And after that, we're going to have the panel session. We're going to have 5 panelists. They would come, they will do a brief introduction and then speak to the topic of the day. And then we have a chance to, just engage them on that topic. After that, hopefully we'll have about 30 minutes left for the program where we can then have questions and answers and just engage, whatever it is that would like to discuss. I'm hoping that today would be fruitful. I am very positive, and I look forward to really getting this conversation started. So without wasting any much of our time, I'd like to introduce Miss Lola Aneke, who is the founder of the C.A.D.E.T Academy, to please give her opening remarks. Miss Lola.
Thank you so much, Dr. B. The energy is already high, and I'm feeling it. Good morning, everyone. Thank you for making our time to be with us today. I'm really excited. And like Dr. B has said, I call her Dr. B, but Sarah has said, it's going to be an exciting time. It's going to be a time of learning, unlearning, and relearning. It's obviously the month of autism awareness and acceptance. And we're gathered here today because we wanted to speak on issues that are real to us. So as an organization, before I go on real quick, I would like to introduce myself to some that may not know me. I'm Lola Aneke, and I am the executive director of C.A.D.E.T Academy. C.A.D.E.T Academy is an acronym for the words Comprehensive Autism and Related Disabilities Education and Training Academy. So it's only right for us to also be in the forefront of advocacy, awareness, and acceptance for individuals with autism. And that's why we put together this webinar, which is titled Understanding the Multidisciplinary Approach Towards Autism Spectrum Disorder in an Inclusive School. And like I said earlier on, the reason we're doing is because like you see online, so you called and we answer. So we've seen schools, parents asking us what it should look like, what a multidisciplinary team should be, what a team should be, what it should look like for individuals with autism, and how that should look like in an inclusive school. So we decided to bring together seasoned experts. So if I'm correct, I think we have almost 80 or 90% of what every team member of a multidisciplinary approach should be as our speakers today. I want to say a big thank you to the speakers. I want to say a big thank you to everyone who registered and who is spending their money with us today. So without much ado, I would like to say welcome, sit tight. Like Dr. B said, it's whatever measure you've come in today that you receive. So I want you to please pay attention, ask as many questions, and let's go make that change in our homes, in our schools, and around the world. Thank you so much for joining, and I appreciate you all. Back to you, Dr. B.
Thank you, thank you. I call her Dr. L. She calls me Dr. B, but really I'm not a doctor yet. So it's okay, you can just refer to me as Basirat. So I'm going to be very strict with time, and that's just because it's a lot we're asking of people today, and it's so important that we keep to time. So our first speaker is Dr. Doris Iwuze. She is the clinical director at Our Lady of Guadalupe Health Foundation. Dr. Doris will be speaking about when and why should a parent become concerned. Dr. Doris, over to you.
Okay, good morning, everyone.
You have 20 minutes.
Okay, good morning, everyone. My name is Dr. Doris Iwuze. Okay, I'm really happy to be here, and I'm going to share my screen. That's fine. I'm going to share my screen right now. So I'll be talking on, let's see. Okay. Can you see my screen? Can you see my screen, please?
Yes, we can. I can.
Okay.
Yes.
All right. Okay. So I'm going to be talking about when and why a parent should be concerned when it comes to talking about special needs, and also telling the doctors about their children. And let me go to the first slide. Okay, I'm almost there. Okay, so thank you, Doctor. Thank you, C.A.D.E.T Academy, Lola, for this wonderful seminar you're doing on autism. And as we all know, April is Autism Awareness Month. And the theme, we all know the theme for this seminar is understanding the multidisciplinary approach towards autism spectrum disorder in an inclusive school. But my own topic is autism spectrum disorder. When and why should a parent be concerned? Most of us do know what autism is. That is a developmental disability that causes significant social, communication, and behavioral challenges in our children. When should you be concerned as a parent? Whenever you notice delays or differences in the milestones of your child. Sometimes it might not be a delay, but it's just different. When you have that intuition as a mother that something is wrong in the way your child plays, learns, or acts, you have to contact your doctor as soon as possible and share your concerns. There was a data from the Developmental Behavioral Journal where they were able to assess the categories of concerns regarding the development of their child as reported by parents prior to diagnosis, what the parents felt before their child was even diagnosed, and how the parents' concerns were related to the later diagnosis of their children, and the extent to which the parents' concerns were associated with the kind of therapies their children received, and then the association between the number of parental concerns, and the clinical measures that children had. After that, when they have finished with the survey, they noticed, and the conclusion was that the developmental concerns, as expressed by the parents, were highly consistent with the diagnosis the child received later. And most of the parents that were able to show those concerns also made earlier contacts with the appropriate professionals, and they received diagnosis for their children earlier. And most of them also got treatments and therapies even before the diagnosis. And the parents who reported concerns across different areas actually endorsed more symptoms during the screening and diagnostic periods. And the results emphasized the need for providers to elicit and take seriously parents' concerns during the referral diagnostic processes. Sometimes parents will have those intuitions and they will go to someone and say, oh, my child is two and he's not talking. Somebody like in our cultural background, they say, oh, don't worry, the father talked at 4. Don't worry, your child will talk later. No, we should pay attention to the intuition and parental concerns about their children during any referral or diagnostic processes. There was also another journal by Benjamin Zaborski and co. The name of the title of the journal was Age of Parental Concern, Diagnosis and Service Initiation Among Children with Autism Spectrum Disorder. And they found out that children whose parents had concerns about their child's verbal communication, that they reported earlier, they had earlier outcomes, and when compared to parents who didn't report to their doctors. And they also found out that children whose parents were concerned about their non-verbal communication, everything is not about talking. There are other developmental milestones prior to the age the child starts talking. Even communication, parents would notice. If you're able to express those concerns to the appropriate people, to your doctors, they found out that the children that they had earlier diagnosis compared to parents who didn't have those specific concerns. So when should you be worried? And you know that most times in our culture, we expect children to start talking by 18 months, 2 years, but that could be late. You can actually become concerned as early as 2 months. By 2 months, when your child is not responding to any sound, your child doesn't watch things as they move, doesn't smile at people, you should be concerned. By 4 months, when your child is not even smiling, cannot hold the head up high, doesn't bring things to the mouth, you should be concerned. I have all these things. I've already submitted the slide, so you can have it later. By 6 months, when your child is not showing affection to the mother, not responding to sounds, the babbling sounds you make to your child, and the child will say it back to you. When the child has problems with the vowels, mama, mama, ba, 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 ba. When the child is not even laughing with you, not squealing with you. When the child seems floppy, I know that is motor. When the child seems tight, you should actually report to your doctor. Doctor, at 18 months, your child has non-verbal communication, not pointing, not waving, doesn't really know what familiar things are for, no imitation, has not gained any new words, even if he or she had words but has not gained any, or there was loss of developmental milestones, you should be concerned. By 2 years, your child doesn't use any two-worded phrases, does not know what things are for, doesn't imitate again, doesn't imitate both the vocal and the motor, doesn't follow simple instructions, doesn't walk steadily. By 3 years, when your child still doesn't obey simple instructions, doesn't want to play with other children, no eye contact, doesn't speak in sentences, doesn't know how to play with toys, no clear words, please go to your doctor. By 4 years, the child is still struggling, no interactive or make-believe play, ignores other children, ignores his or her name, doesn't have adaptive skills like dressing, using the toilet, cannot retell a favorite story, doesn't understand the same and different, and has pronoun reversal, doesn't speak clearly. And 5 years, cannot say the first name, the last name, the sex, doesn't respond to people or just respond superficially, cannot have back and forth discussion with you, is easily distracted, not paying attention, not focused, has repetitive behaviors. And sometimes we do diagnose children as late as 20 years, adolescents having late diagnosis. So in an older child, when the child has difficulty starting conversations, difficulty making friends and interacting with others, has repetitive language, uncomfortable with changes to routines, extremely passionate about specific topics or objects, you should be concerned. So anytime you notice developmental delays, we need to know the signs and do what? Act early. So when you have noticed these things, what should you do? These are the things you should share with your doctors. You should let them know the things you and your baby can do together. Some things your baby likes to do. Do you think your baby is always doing the same thing over and over again, eating from the same plate over and over again, difficulty in changing routines or transitioning from one activity or the other? Are there things that your baby does that makes you so concerned? You've been calling the name as early as 12 months, 2 years, the baby is not listening to you, not responding, has no words. Do you think your baby has lost any developmental milestones? Because sometimes they improve, they're talking, and then around the 18 months, they will start losing their speech or things they used to do before. Does the baby have any special healthcare needs, or was the baby born prematurely? Because actually, when it comes to developmental milestones, the premature babies, you need to have their real age, calculated age. It doesn't normalize to their 18 years. So prior to that, they have to subtract that 7 months that they lost when they were in utero. So that is what they will use to judge the developmental milestones. So your doctor will look at all these developmental concerns and then tell you what to do. Oh, I'm trying to scroll down. Okay. Oh, okay. I think it's stuck somewhere. Okay, so I've seen it. So sometimes you can detect autism as early as 18 months or younger, and by 2 years, a child should have a diagnosis. Sometimes, even when it's not clear, it doesn't mean that you shouldn't do something about it. Because some children do receive later diagnoses, and even though they receive later diagnoses, this delay means that the parents might not get the help that they deserve. So diagnosing children with autism as early as possible will help your child receive the services and support they need to reach their full potentials. And it also helps parents to interact closely with their children, helps them with their adaptive behaviors, their communication and socialization. Because when you know what you're dealing with, it means that you're ready to fight it. What's the way forward for our parents? Developmental monitoring. Sometimes remember that children with autism are children first and foremost, and because of that, they can still have any other ailment, any other diseases, just like any other person. You can have a child with autism and Down syndrome together. You can have a child with autism, sickle cell disease, hypothyroidism, all in one child. Do you know that? So when a child didn't cry at birth and had what we call birth asphyxia, or seizures in neonatal period, or cerebral palsy, that child needs to be assessed, or the developmental milestones should be screened as early as possible, even from 2 months, from 3 months, every month. Then the surveillance, having that high index of suspicion that something is wrong with your child. And this can be by the parents, the grandparents, extended families, the teachers, even the doctors. And then after the surveillance, we have the screening where they will compare your child's developmental milestones with age-related, age-appropriate tools. And if they feel that their child has met that mark, they will now do the assessment and the diagnosis. Why must you get your child? Why must you tell your daughter? Why must you say that, oh, I don't feel that everything is okay with my child? Because if you do that, you're going to equip your child to manage some of the specific challenges they may face in the wider world. The earlier, the better. There are some things you can work with as an infant, school-age child. But when that child becomes an adolescent, an adult, it becomes extremely very important. And if you're able to teach your child at least those developmental milestones they're supposed to acquire, it means that as the child is growing older, they will use those skills to better themselves. And they use it in different settings. Like if you teach a child to initiate contact, initiate social interaction, it means that by the time they go to school, they can initiate that with their classmates, they can play with others, they can respond to teachers. And it will also help you, secondly, to identify and treat comorbidities early. You know, our children have a lot of comorbidities. Some of them have gut issues that wouldn't allow them to pay attention. Some of them do have attention deficit hyperactive disorders. Some of them have sensory issues. And when all those things come bearing down on our kids, they are not able to behave appropriately. It affects even their learning. So we're losing a lot of time we would have used to acquire more skills. It's going to help to prevent, reduce, and treat mental health issues. I tell you, some of our adolescents and adults do have mental health issues. They have OCDs, they have depression, they have panic attacks, they have anxieties. These are real. But if you start early to work with your child, at least you can curb it. Do you know some of our adolescents do have suicidal ideations because by then they know they are really different. But when they start accepting whom they are as early as possible, it makes a whole lot of difference. It will help you rule out other possible causes of behavioral issues in our children. What if they have hearing loss? You know, you can have a child with autism and hearing loss. What if they have hearing loss? How would you help? If you don't start early, if you don't take those developmental milestones, the child is not responding, doesn't mean it's autism all the time. Then it can also help you start medications that would help your child. If your child has seizure disorders, at that point in time, your child oxygen might not be circulating to some parts of the brain, and sometimes it can have permanent brain damage. So you can start anti-seizures on time to prevent complications. What about it will help you also to seek other multidisciplinary team your child needs. It will help your child to receive intervention services even before diagnosis. You know, if you're under insurance, especially if you're outside Nigeria in the Western world, according to the IEP plan, individualized educational plan, so long as your child has delays, significant delays in these developmental milestones, they will get you someone, they will get you those services you need, even before your child starts school at the age of 4. And they can allow your child to actually start school by 3 years. But by then, they would have had someone come to your house to work with your child. So early intervention helps you to improve significant difficulties, prevent subsequent neurodevelopmental disturbances arising from improvised social emotional interaction in the first years of life. What does it mean? You know, as a parent, we work with our children when they're younger. You know, you babble with them, you play with them. But when your child is not doing all that, you say, "Oh, my child is pretty independent. Allow him to do whatever he or she likes. My child can play with us," not knowing those things are just stereotypicals of autism, just lining up toys, not really playing with them. So you're going to lose that moment with your child. So young children with autism benefit from early intervention programs, and it's an opportunity for you as parents to implement those strategies through supervision from your caregivers. You will be amenable, you'll be ready to receive both the diagnosis, receive the management plans that have been given to you. You work with your therapist. So in conclusion, parental concerns and intuitions are valid. Never underestimate the concern of a parent, because when parents are involved from the beginning in therapy with acceptance and adequate understanding of the diagnosis, the whole intervention runs better and more successful, because significant delays might occur and the opportunities for intervention might be lost with late diagnosis. So getting services as early as possible can make a difference in the development of a child with autism or other developmental problems, even if it's not autism. So thank you for listening, and let us listen to our parents. God bless you.
Thank you, Dr. Doris. Thank you so much. This is an amazing start for me. You have brought up really significant things. The family system, which is where everything starts from. So, what the parents notice. And I know you did cite instances where what parents suspected happened. So first of all, let me say thank you. Please, everyone, use your Zoom hands to clap for Dr. Doris. If you have any questions, put them in the chat, and I'll try to pick them up. So I haven't found any question just yet. So I'm going to say two things, just as reflections that came to me while you were talking. There were some studies that were done in Nigeria, in Lagos particularly, and it was found that the earliest age that parents of children have developmental disorders started to notice that there was something. The average age was about 2 years. Yet, the average age of diagnosis is around 6 years. So that's a solid 4 years between when the parents first notice something and when they actually get a diagnosis. Between this period, a number of things happen. Either parents are seeking help, trying to find ways to help they haven't found. So for me, it brings me to the question I'd like to ask Dr. Doris. Given this wide gap between noticing and actually getting a diagnosis, what can you say to the practical challenges of actually getting a diagnosis? Because between this period, there are some difficulties that parents encounter before they're actually able to get a diagnosis for their children, from the time they notice a 2 and when they actually get average age of 6. So what can you say about the practical difficulties of getting this diagnosis and how to go about it?
Autism, even though many people know about autism right now, sometimes it can be difficult to be diagnosed by people that are not well trained or versed in this spectrum of children. And it's not everyone that can diagnose autism. We have poor manpower. We have limited facilities that can really diagnose a child. Sometimes the cultural issues of harmony in the family. Sometimes I've seen where a mother has those beautiful intuition, and if you look into it, you know that she's right. But the father said, no, nothing is wrong with my child. So you see those disharmonies in the families. And because of our culture, if the man refuses or if one parent refuses, it will make the diagnosis delayed in a child. So I've also had concerns where schools would tell a parent that I think your child needs to go for further diagnosis, and the parent said nothing is wrong with my child. But this is when the school has noticed it, but the parents are still in denial, or maybe it's their first child, so they didn't have any other sibling to compare with, so they didn't know about that. But for parents that notice it early, maybe they are also concerned about things they are not aware of. So maybe they have also practically approached other people to tell them, oh, I think something is wrong with my child. But those people, the feedback, because of ignorance, the feedback they will give them, don't worry, especially if it's a boy. Boys talk late. Don't worry, your child will talk. I don't think anything is wrong with your child. Or let us go and see our pastor, or let's go to the church and pray, or let's go to the mosque. So these are cultural issues that are also affecting early diagnosis in our children. And because they don't want to be discriminated against, they don't want people to see them as if their child has a big issue or their child is on quote nuts. Typical, I don't want to use the other words they use. So they don't want people to see that. They keep on hoping that something will get better until it's obvious that this is affecting the child's ability to learn in school. But what I tell mothers, my own advocacy is, no matter what people say, once you have that intuition that something is right, even if your child is not diagnosed, seek for help, no matter how little. If by the age of 18 months your child is not walking, don't even wait for anybody. Go do your physiotherapy. Anything you can do to help your child gain milestones positively without harming your child, go for it. You get that diagnosis. At this age and era, do not wait.
Thank you very much. I think that's the critical thing that you have said. You may face these challenges between the time that you first notice something's not right and when you eventually get a diagnosis. But between that time, try whatever you can for the child. But you did mention, and I'm still waiting. I'm waiting. If anyone has anything, please raise your hand. I will. I'm constantly looking at the participant list to see if there are any hands up. Raise your hands and I'll call you to just speak, really briefly. So whilst we're waiting for that, you spoke about cultural factors. And I know this is autism awareness and acceptance that we're talking about. So there's this line between trying to help the child and actually accepting the child. So where exactly, because there are arguments that, trying to make a child talk, a child is not talking, we say talking is a milestone, but trying to make a child talk is like trying to make a child with autism communicate the way we communicate, not accepting the way they communicate. Maybe they're choosing not to communicate as much as we do. And so where do we draw the line between pushing clinical or medical, approaches to intervention and actually just recognizing or accepting the child for who they've presented themselves to be to us? How do we manage that?
No, if I understood you correctly, you mean that our accepting the child for whom they are and working with them the way they are, right? Is that what that's your question in summary, right?
Yes.
Okay.
Accepting them for who they are and working with them for who they are versus clinically saying that we're intervening when in fact when we intervene, we are trying to make them more like us.
Okay. Oh, I love this question. Yeah. So let me start with working with the child the way they are. You see, that is why I love the applied behavioral analysis. If you study the behavior of a child, you understand why they behave the way they do. So if you understand that, it means that you can just make that thing. If you can work on the antecedent, what happens before the behavior, you can influence the behavior and the consequences of your child. And remember, we are the parents. If you understand your child, and as a parent and as a caregiver, you will know that there are skills. You wouldn't allow them to remain the way they are. You can use the opportunity with what they have to improve and gain more skills for them. So if child has capacity to talk, the child, you've heard the child say several words, that's an example. The child has said several words, has up to 20 words, but the child is not using it for communication. You pay the child to say the word. So if the child is hungry, for an example, and the child screams because he's hungry, and then you give the child food, what's the behavior? Is that the way the child was made? So if you give food to that child, that crying, the incidence of crying will increase because he's doing what? Getting the food for the child. You wouldn't say that's just the way the child communicates, but we've understood the behavior of the child. So what if you get the child to say the word food? And anytime the child gets the word food, it gets the real food for the child. What happens? Antecedent, the behavior and the consequences of getting food because the child has used that word food. The child will not scream for food. The child will say food to access food. So in terms of medical intervention is not applied behavioral analysis. Medical intervention is to work on those comorbidities that would affect learning for our child. They are all together. If you don't handle seizure disorders in the hospital, the child will do 2 steps forward and 1 step backward. Because anytime the child has seizure, the child wouldn't have access to treatment facilities, wouldn't go to school or go receive therapy, and the child might actually have permanent brain damage. If your child has hypothyroidism, that child will have difficulty in learning, and that's medical. But when it comes to applied behavioral analysis, we just study the way the child learns first. Is it did what we call district trial training? Is it incidental naturalistic teaching? You observe the way the child learns first and use it to improve and multiply the skills the child has. So they go hand in hand.
Thank you, thank you, thank you. I have a few people talking in the comment section. Someone said communication is not talking. Thank you, Dr. Doris. It's about teaching skills. Communication goes beyond talking. Sado Amina says, my name is Sado Amina. I'm an aspiring special needs teacher. I believe with most parents, special needs education is something they're not used to, partly because they do not really know that a special needs child can be anything he or she wants to be in the future. They believe that a special needs child is just a hopeless person, and hence there's always room for denial. So I guess this speaks to, you know, the whole parents' understanding of the potentials, you know, that the potentials are also limitless for children with special needs, just as they are for children without special needs. We have a lot of people talking about communication not only being about talking or being verbal. I have a question from Abiola. Dr. Doris, would you agree that autism is easier to diagnose in boys than girls? I came across this school of thought while doing research, and I wonder why this may be so, because some boys are actually reserved naturally and some girls are really extroverted. How do we reconcile this?
Okay, so think of the question, autism is more in boys than in girls, and it has to do with genetics. Part of autism is 4 times more in boys than in girls. But when it comes to autism, remember, we have diagnostic criteria. So if someone is an extrovert, and like in girls, you know, girls have more communication skills than in boys, but that doesn't mean that they wouldn't be diagnosed with autism, because so long as they have met that diagnostic criteria. You know, you can be an extrovert, but you're shouting, you're dancing, but you're not really having social interaction, one-on-one, or back and forth communication, age-related skills that's supposed to do with others. That will be counted for you. You might be reserved, okay? You might be reserved, but if you watch closely, that's why you just don't make that diagnosis immediately. You need to observe your child. So if you're a boy and the child is reserved, then that is why you observe the child. You have your what we call anecdotal observation. Watch the child in his or her natural environment. It can be in the school, it can be in the house. How does the child relate with his environment? Relate with others, the behavior of the child. The child can still be talking, can still be discussing with at least the parents, the siblings, one-on-one, back and forth communication, good thought process. That child might not have autism. So it depends on the diagnosis. But do you know what? I will still repeat myself. No matter what it is, whether you have early diagnosis or late diagnosis, once you have seen that your child has developmental delays, even if the child is an extrovert or an introvert, seek for help or get help for your child. That is very important. Till you get the diagnosis, don't let the diagnosis stop you from accessing the help the child needs. That help that will affect the child's ability to communicate, not necessarily to speak, to communicate with his environment and learn appropriate skills. Look for solution for it.
Thank you, Dr. Darius. Thank you, Dr. Darius. Yes, the statistics may say boys are more prone to autism than girls. It's just there are other factors, you know. Maybe girls are not being diagnosed the same way. Maybe girls are hidden. Maybe gender roles are hiding girls and they're not, you know, being exposed to diagnosis. There's so many other factors, but I think what Dr. Doris said is something that we should all be tweeting about. We should use hashtag Autism Awareness 2022. Tweet about it. Don't let diagnosis stop you from accessing the help that you need. So I'm going to move to the second speaker now, Mrs. Daisy Jonathan. She is the Director of Pleasant Places Education and Therapy Centers in Lagos and in Port Harcourt. Mrs. Daisy would be speaking about the multidisciplinary approach towards autism spectrum disorder. Mrs. Daisy, over to you.
Hello, everyone. That was quite, I wasn't expecting to be called so fast. I thought there would be some preambles. Good morning. And I'm really excited to be a part of it. Thank you so much, Lola and the C.A.D.E.T Academy team for having me. And thank you to Dr. Doris. That was a beautiful presentation as always. God bless you. I'm supposed to be talking about the multidisciplinary approach within the inclusive education system. I'm trying quite hard to, forgive me, technology. I decided to upgrade to what's it called, the MacBook, and the MacBook is really dealing with me seriously. I'm trying to get my presentation up, but I will just keep talking and then hopefully I'm able to get that done as fast as is. See, oh, no, this is not nice, sorry. Okay. I don't know if we can see my screen now. Not yet?
Not yet.
Yet.
Oh, no. Can we see it now?
Not yet.
And this is where technology comes in. So sorry. Share.
Okay, so
Okay,
may
if
I
this is not coming
suggest?
on, I will just.
Yeah.
Is that one not your slippers, Toby? Is in the box.
Can we have ourselves muted, please? Can we have everyone muted, please? This is the noise we spoke about. Please, let's have everyone muted. I was going to suggest if speaker 3, Mrs. Damilola or
Yeah,
Yolaja is ready, if she can come on, if she's happy to come on now, then you can send your presentation. Can tech person please mute everyone? Thank you. Tech person, please put everyone on mute so that you are the only person who can unmute them. If Mrs. Damilola is ready to, if Mrs. Damilola is ready to come on, Mrs. Damilola can come on, and then Miss Daisy, maybe you can send your presentation to Lola, and the tech guy can share for us. Is that okay?
Absolutely, yes, good. The tech guy can share your slide.
Yeah, so
you can send it to me.
Mrs. Damilola, are you ready?
Damilola is not ready.
Damilola is not ready. Okay, we'll wait. We'll just wait then, and then let Mrs. Daisy email hers, and then we'll have the tech team share it.
Daisy, you can send it to me on WhatsApp. Whatever works for you. Email. Oh, email. I'll do that right now. lola@aneke@gmail.com. LOLAANE@gmail.com. I just sent it to you.
Thank you. I can see that.
This meeting
I
is
can
being
see the conversation going on in the chat section. So yes, communication is not only about talking. There are other means of communicating apart from using words. There are functional communication procedures. Who asked this question? I think it was Agbinya Mario. Agbinya, are you happy with the response that you've received, or would you still like clarification while we're waiting for Mrs. Daisy?
May I just suggest that someone else starts, and then I'll come on
Okay,
later.
So the third speaker isn't here. Damilola isn't here yet. And so that means that we will bump this up a bit. Do we have our short video? So we have 5 minutes for a video. Can we take the video now?
Okay, I think we can take the video.
Let's take the video now while we sort out the tech issues. And then when we come back, the tech issue still hasn't been resolved, then we'll move to the next session.
Yes, absolutely.
All right, please, let's have the video.
Uncertainties and moral decline. The Cadet Academy is proud to introduce its inclusive school, catering to the educational needs of children of nursery to primary 6. In these days of uncertainties and moral decline, many children as young as below 10 are having to deal with the terrible influences of drugs, alcohol, sex, violence, unhealthy obsession with money, and other societal vices. No matter the religious or cultural background, most parents want their kids to grow with an understanding of godly truth about life. This is why the Cadet Academy Inclusive School adopts the unique Alpha Christian Education ACE curriculum, which is founded on godly principles and has been utilized for more than 50 years, and currently in over 145 countries. The ACE curriculum is broken down into bite-sized colorful self-paced workbooks called PACES, which are carefully designed to develop thinking skills and create mastery and godly character in and out of the classroom. At the Cadet Academy Inclusive School, your child will enjoy excellent mastery-based individualized learning, built-in reinforced system of learning, development of critical thinking skills, socialization, and godly character training. Enrollment of nursery to primary 6 pupils for admission into the Cadet Academy Inclusive School begins on the 2nd of May 2022 for the academic session starting in September 2022. Register your child from 2nd to 30th May and get a 10% discount. To learn more about the Cadet Academy Inclusive School and the ACE curriculum, visit our website at www.cacademy.sch.ung/inclusiveschool. The demand for personal and professional development training skills. Parents and educators. The demand for personal and professional development training is experiencing a boom, especially in the education space. Schools and related organizations are looking to provide their teachers or other staff with vital soft skills. Parents and educators are looking to build their own expertise, knowledge and confidence, as well as expanding their career opportunities. The demand for personal and professional development training is experiencing a boom, especially in the education space. Schools and related organizations are looking to provide their teachers or other staff with vital soft skills. Parents and educators are looking to build their own expertise. Opportunities. Teachers and The demand for personal and professional development training is experiencing a boom, especially in the education space. Schools and related organizations are looking to provide their teachers or other staff with vital soft skills. Parents and educators are looking to build their own expertise, knowledge and confidence, as well as expanding their career opportunities. Teachers and special educators' engagement and performance can be improved by the Cadet Academy's effective personal and professional development training programs. Whether it's teaching
Well done, Cadet Academy. This is a welcome development in the space. You know, just having more schools and a bigger space that can get to children. I think this is fantastic. Well done. Do we have Mrs. Daisy's presentation just yet?
Unfortunately, no. But I could actually just, have you seen it, Lola? Have you received it now?
It hasn't come in. I'm serious. I've refreshed again.
But I can actually go on with my presentation. I can just, without sharing, and then I can always email it to participants if that's needed. So that doesn't stop us. Does that work?
All right, we'll go with that. Let's go with that. Okay. Since Damilola isn't ready, let's go with that.
Okay. A bit clumsy though. I'm so sorry. I sincerely apologize. And I've got 15 minutes, so I'll be as fast as possible. Dr. Doris has laid a very good foundation, you know, for us all. And it's important that we just quickly stress out a few terms or terminologies that will guide our thoughts while I make the next presentation. First, we will look at autism as a spectrum disorder, and the key word there is the word spectrum. And this means that autism presents, you know, with a wide range of, you know, symptoms and, you know, presentations from mild to severe. And then, of course, it means that we have diverse range of symptoms and diverse needs, diverse, you know, challenges occurring from individual to individual. As a parent and as a professional, what I see most times when you tell people that, oh, my son is autistic, or I work with children with autism, that, oh, yeah, they're quite gifted. But what we cease to understand is that within the entire spectrum, you know, there's, you know, of course, you have those who are gifted, and everyone, of course, is gifted in one way or the other, but also it ranges in terms of the symptoms, in terms of the presentations, and there are actually quite some levels of autism that are actually quite severe, such that the persons are unable to, you know, do the day-to-day work, you know, that is expected for that age. Also, I wanted to stress out on the challenges with differential diagnosis. Dr. Doris also mentioned it a bit. Autism spectrum disorder results, or it relates with several other disorders and syndromes that, you know, kind of have been lumped together, and it's called autism. So when we talk about autism, especially in Africa and especially in Nigeria, we tend to want to think about everything as autism, whereas there are other, you know, little disorders here and there. Little, I don't mean little in terms of it not being severe enough, but there are several others who, you know, that are out there that have been lumped under the autism umbrella. For example, we have Norris syndrome. So when some people would say, oh, I work with someone who is blind and autistic, you know, we could actually be dealing with Norris syndrome, where the individual, you know, present with autistic-like, you know, symptoms, but also has, you know, visual, you know, disorders or visual deficits. We also have, you know, ADHD that is always, you know, lumped together with autism. That's supposed to be, you know, like a diagnosis on its own. And then, of course, there are several others, Rett syndrome, and so on and so forth. Now, these are, you know, disorders on their own. They're supposed to be diagnosed differently, but because we have challenges, not just in Africa or in Nigeria, globally, there's a challenge with differential diagnosis in autism. We tend to want to put everything together because a lot of the symptoms either overlap or they look similar, or, you know, somehow they are related to the same symptoms, the same presentations that we have with autism spectrum disorders. I also want to point out that with autism, we also have several comorbidities. Dr. Doris also mentioned that quite briefly. And so I often would tell people that autism hardly ever works alone. You know, autism usually would drag along one or two other friends: ADHD, anxiety disorders, seizures, sensory processing issues. Now, these are other comorbidities, there are other symptoms, there are other disorders that are linked. They could stand on their own, but a lot of them, also go together with autism. Most times, one of the challenges we have in the education system is that when children are brought to us, what's the diagnosis? Autism. And we don't get to know what other comorbid disorders have been lumped together under that umbrella term autism or autism spectrum disorder. I also want to point out, as we all know, that autism is diagnosed by a triad of impairments, but it actually also has several deficits. So while we're looking at communication deficits, we're looking at social skills deficits, we're looking at stereotypical and repetitive behaviors that occur with autism, we also know that there are other deficits that are unique to each individual. For example, I've already mentioned the sensory processing disorders that could happen. We have issues with, speech and language, which could be there. We have, issues with fine and gross motor skills, bilateral coordination, quite a lot of other things that are there that also occur, as deficits together or under the umbrella of autism. So despite the fact that the focus usually during diagnosis is on the triad of impairment, there are also other things that we have to look at. Now, looking at autism, from what I have mentioned, the differential diagnosis, the comorbidities, the triad of impairments, and then of course, all the other issues that come under autism that occur with persons with autism, we see that autism is not a simple disorder. It's actually a complex disorder made up of several different parts. And what it means is that for the child or the individual with autism to thrive, we must be able to address every specific need of that individual. And that includes the medical needs, the social needs, the needs in terms of, is this person able to write in the classroom? The social needs, is this person able to interact? Is this person able to sit down, settle and listen, attention, attending skills? All of those have to be met individually or, differently for that individual to be able to thrive within the school environment. And it's for this reason that we need to have a group of professionals who come together, who have been specifically trained to assess and address these tiny needs that occur across the lifestyle, across the lifespan of the individual, because sometimes they're not there when they're, when they're children, when they're 3 to 5 year old. I often tell people when they do assessments or when I see assessment reports and it says, oh, we're testing for attention and attending skills, and the child we're talking about is just a 2-year-old. No, we don't look at attention and attending at 2 years because we don't want them to be quiet and settled. A child who is 2 years, who is 3 years should be running around, actually, should be interacting with the environment, should be touching things, should be feeling the environment and understanding it. So some of these may not be there as a 2-year-old, or we may not focus on attention skills, for example, in a 2-year-old, but it may become an issue when the person, turns 6 or turns, 10 and is getting ready for, secondary school and all of that. So the professionals come together because they have been specifically trained to assess and address these specific needs and the areas of deficits. And these professionals are the people we call the multidisciplinary team that every school should have. I haven't said the multidisciplinary team in schools. I have said the multidisciplinary team that every school should have, because it's one of the weaknesses of our education system. We do not have the MDTs in the schools. Schools just run and say they're inclusive. Now, what is an MDT? What is a multidisciplinary team? This is a team that is made up of different professionals who are responsible for assessing and addressing the diverse needs of persons with autism spectrum disorder. Now, because we're focusing on autism, that's why I'm using autism spectrum disorder, but actually the diverse needs of persons with intellectual and developmental disabilities. Now, this includes the general education teacher, which we have in every school, so the teachers are the general education teachers. And then we have the special education teachers who have been specially trained to teach children who learn specially. And they are different. The training is different from that of a general education teacher. And each of them have their own roles, they have their own responsibilities, and they're not supposed to, get into each other's space or do each other's job like we usually see. Of course, we have the behavior analysts. My sister behavior person has talked a lot about behavior analysis. So every multidisciplinary team should have that, because we do know that one of the diagnostic criteria for autism is the behavior, the behavioral aspect of it. Not that autism is a behavioral disorder, but because a lot of everything that the person does is behavior. We say behavior is what everyone does. If a dead man can do it, then it's not behavior. So everything that the person does is behavior, and that's why there has to be a behavior analyst as a part of the multidisciplinary team. Of course, we have the speech and language professionals where the person has a speech and language deficit as different from a communication deficit. One of the questions that came up quite a lot was about the issue of communication and speaking. Communication is not the same thing as talking. So if we're focusing on talking, yes, we need a speech and language professional, but there's also a part of applied behavior analysis that talks about verbal behavior. And we say someone does not have to be vocal to be verbal. So you can be verbal and communicate in different ways without actually using sounds or words. Back to the topic, we also have occupational therapists, we have physical therapists, we have physiotherapists, quite a lot of them who may make up the multidisciplinary team in a school setting. Now, what are their roles in the school environment? The MBT ensures that individuals with ASD are properly assessed. Now, without proper assessment, we do not have a foundation for planning. And of course, without proper planning, we do not have the foundation for implementation. And without proper implementation, then we cannot have individuals who are, able to be independent and functional, and live their daily lives, the way they're supposed to live it. So the bedrock of it all, when we're talking in the school environment, is assessment. So we must have proper assessments done by a team that understands the different aspects of these individuals' challenges, these individuals' needs. And then the team is able to assess and begin to say, these are my recommendations for planning. And then, of course, during the planning, the support is there and then implementation is there. I'll give you a very good example. In school environment, we expect that when children come to school, they are able to learn, sit down, attend, learn. They are able to write, if possible. They're able to answer questions. They're able to interact, work in small teams and all of that. Now, for that simple thing I have mentioned, we may need 3 to 4 or 5 different professionals to be able to assess whether the child is able, what we call school ready, or able to work within that environment that the child has been thrown into. I use the word thrown into because sometimes we pick schools based on how the school looks, how big it is, how popular the school is, without looking at the child, the individual. Is this person ready for this environment? We talk about ecological assessments. Are we able to really look at that environment and say, does this environment fit this individual, rather than just putting that individual in that school and expecting the individual to fit into the school? So the MDT assesses this child, but not just the child. The MDT also assesses the environment that we're bringing the child into. What are the resources that we have as a school? What are the resources we have in terms of professionals to work with this child? So when a child comes in, or when an individual comes into a school environment, because I prefer to use individual, it could be, a teenager, it could be an adult, so it must not always be a child. Now, when the individual comes into the school environment, the assessment is not just for that individual. The assessment goes beyond that person. Yes, we have to assess the needs of the individual. We have to assess, what are the strengths, what are the weaknesses, what are the specific learning channels that this individual already has. And then we look at our environments. That's where the ecological assessment comes in. We look at our environment. Does this environment fit or meet the needs of this child? I remember a couple of years ago when someone brought in a child who had cerebral palsy, quite severe. And I said, the class this child is supposed to be in is upstairs. We do not have the ramps. We don't have a building is not built for this child. And it's going to be a risk for this child to be admitted. And then the parent felt that I was being discriminatory. And I had to explain to her that no, we also have to assess our needs. Do we have what it takes to take in this child and give the child the best? So that's very important when we're talking about inclusion in education. I'll quickly talk about inclusive education, which we'll all talk about. Diversity and inclusion, it's thrown around a lot, even in the workplace. We have, in terms of LGBT, so people talk about diversity and inclusion in terms of the gay movement, in terms of female equality, and all of that. But we're going to look at it in terms of persons who are neurodiverse. You know, everyone is neurodiverse, that's the truth. So we now do not talk about neurotypical, we're talking about the neurodiverse population, because every person in the school environment learns differently, has their different challenges, have their different needs, and each of those needs, whether psychosocial, whether physical, whether behavioral, has to be met one way or the other. Now, one misconception we have about inclusion is that inclusion is merely about equality. And that's where we get it wrong at schools. Inclusion is not equality, because equal is not always fair. You know, so inclusion is about equal access. So there has to be equal access to education services for everyone. So everyone has to have a right, you know, the right to education has to be met. The right to inclusive education has to be met. So there has to be equal access to education services. There has to be equal considerations in planning and equality in terms of implementation of education programs. So why do I say inclusion is not just about equality? If we treat everybody as equals, then we're going to leave some children behind, because we don't all learn equally. We don't have equal experiences. We don't have equal needs. So when we're saying bring the child to the school, we treat all children the same. We don't want you to treat all children the same, because every child is different, and the needs of the child has to be met in a different way with a different approach. So inclusion is recognizing that the world is made up of neurodiverse persons, including you and I, and everyone's needs must be met equally. So it's not about equality, it's about meeting the needs in an equal way, equal concentrations, equality in planning, equality in implementation. Now, inclusive education is a right. We know that. We can, I mean, a quick Google search will show us what the UN Convention says on the rights of persons with disabilities. There's a right to education. We have all of that. I think we also have an inclusive education plan for Nigeria. You know, we have what the C.A.D.E.T says and all of that in the 2030 Agenda for Sustainable Development. We have it there, what they call the Agenda 2030. We have it there that, you know, inclusive education is important. And then there's an emphasis on quality and learning. And that's the emphasis I also want to make today, quality and learning. So it's not just about putting a child in a school. You know, when you go to a school, they say, oh, we are inclusive, we accept children with needs. That's not what we want. What we're saying is there has to be quality education, and the learning that they receive has to be the learning that meets their needs, and it has to be top notch, not just we accept them and then we leave them in the class, you know, to do whatever they want to do. We want them to write the same exams, it's the same curriculum. That's not inclusive education. With inclusive education, we are meeting the individual needs of the individual child or the individual students. Now, we've talked about the role of the MDT in schools. I will just quickly say that the multidisciplinary team in a school environment brings on board their different skills. So the occupational therapist is coming with skills that the behavior analyst does not have. It's sad when people want to be jack of all trade, masters of none. The special education teacher, I happen to have a master's in special education. I'm also a qualified behavior analyst. They're different. We talk about behavior analysis in special education, but it's just a module. It's just mentioning so that you are aware. It does not make you a behavior analyst. Don't do the work of a behavior analyst. And the behavior analyst, there's a difference between being a verbal behavior person and of course, if you're a behavior analyst and you have not trained especially in verbal behavior, don't go ahead to be doing verbal behavior, because you could just easily model up that child. And of course, if you're doing verbal behavior, don't say you are a SALT. You're not a speech and language therapist. You're different. Your skills are different. The skill sets are different. The trainings are different. The competence is different. And everyone brings their individual strengths to the table for whose benefit, not for the benefit of the school or of the parent, but for the benefit of the individual child. And that is very important. MDTs should form a part of the assessment. So once a child comes to you and you have done your initial consultations and you have seen that this child is coming with mobility issues, this child is coming with issues with writing, this child is coming with sensory processing issues, don't just say, oh, bring the child to my school. Yeah, here we do inclusive education. No, it's your responsibility to look out and set up a multidisciplinary team, looking at the needs of this child. Do I need somebody to come do speech and language therapy? Starting from the assessment, do I need a behavior analyst on board? Do I need an occupational therapist on board? Do I need a physiotherapist on board? A general education teacher has to be there to say, this is our general curriculum, but a special education teacher has to be there to say, this is how we will tailor this curriculum to the needs of this person. It's not a one size fits all, and it's not something we run through and say, oh, we're doing inclusive education. It has to be done properly for it to be right. They also provide a joint and integrated approach to meeting the needs of the person. I've talked about that. So they work together. They are not at loggerheads. They are not fighting for relevance. Everyone is a professional in their own right. So they work together and their approach is integrated. And the whole focus is on one person. In Nigeria, we say the customer is always right. But who is the customer in this point? It's not the parent. It's for the need of the child to be met. And that's your primary and your key customer when you work. Now, one of the major challenges we have with the entities in schools is that collaboration is usually quite lacking in what you do. And that's because in Nigeria, education is in the hand of the private practitioners. So schools are owned, I mean, almost everyone goes to a private school and all of that. Very few are in the government setting. And because parents pay for education, it also means that they have a lot of say, often not informed. So sometimes they say that the parents, and trust me, I'm a parent myself, so I'm speaking from the perspective of a parent, is not always informed and may be wrong. And because schools don't want to lose out on income, you know, they tend to want to just, okay, yes, that's what we want. And then the child suffers. So it's important that we have collaboration among professionals. There's a need for the team approach beginning from assessments when the child comes to you, because they will see things that you are not seeing, and they will be able to link it up together properly and help the individual. Normalized consultations with key professionals. I find it quite difficult to understand why we think consulting with other professionals is, even within the same field, it means that you're weak. Actually, it's a sign of strength. So normalize consultations with other key professionals. Learn to call up somebody to say, hello, Lola, you know, I have this child that was brought to me, and this is it. What do you think, you know, about this? And she's able to give you her own perspective. Talk to somebody. If you're giving an adult, I mean, I think I've had someone who is 35 or so come to me. They brought a child, an individual who is 35 years, and I said, I'm not skilled in working with that age, with that population. And it's important that you know when to say no. So recognize your strengths, recognize your limitations, and learn to refer. So build and encourage a strong referral system. Again, schools should be able to work and encourage, teamwork and collaborations. Parents need to be trained and educated and carried along. They have to be a key voice. So for them to be a key, useful voice, then they need to have trainings and education. And it's not always about a conference or a seminar. It may be just giving them a book, giving them a pamphlet, giving them an article to read or a journal, and then they are able to. We also must look at a person-centered approach. The individual is always key. And then lastly, I want to talk about ethical practice and professionalism among key workers. Now, if I do know that if I refer my students to, let's say, a psychologist, the psychologist will refer that student back to me, then I would want to refer a lot more. Now, a lot of professionals, especially in Africa and Nigeria, do not have ethical practice and professionalism. It's all about, the money, the money, the money. So someone refers to you and says, oh, go meet this person, and she would help you with this aspect of your child's diagnosis. They get to that person's office and the person says, oh, I have another friend who is better than the person that referred you. And that is really very, very unethical. So we should learn to, stick within professionalism and ethical practice and ensure that, the person that are referred to us, we are treating them how, as expected, and then we're referring back. And even if we're not referring back, we also have to be sure that your own practice is, quite professional. I find it quite difficult to refer people, because I keep saying, oh, sorry, I've not used their services, but, I hear. So we need to be able to, and that brings us back to maybe something for another day, Lola. We have to start looking at a database for professionals. Who are they? What are their qualifications? How many years have they worked? Who supervises them? What boards do they belong to? Are they in good standing? What competencies do they have? So we have to start looking at that so that when we're doing the referrals and setting up the teams, we're doing it with confidence, knowing that these people actually know what they're doing and will be good for us. Our settings. In conclusion, I want to say that inclusion is not about the education setting. Inclusion can take place in a special education setting. It can take place in a general education setting, and of course, in an inclusive school. So it's not always about the educational setting. Inclusion is about meeting the needs of the individual within an environment that works best for them and ensuring that they have equal access to the services that they need as individuals. Of course, we do have challenges to inclusion in education. One is the fact that low expectations. Once you tell somebody that this person has an autism diagnosis, sometimes the schools just assume that it means that they have an intellectual disability, and it's not always true. They may or may not have intellectual disabilities. So we also have the myths, the misconceptions about autism, about giftedness. Oh, they will cope. And then you put a child in year 6 just because he looks big, and then the child hasn't learned the foundational aspect. The child cannot even string from 1 to 10, and then the child has to be in year 6 because of the age, without an IEP, without a plan, without anything tailored to their specific needs. And then, of course, we have the misconceptions about aggression and challenging behaviors, where people just think that, oh, everybody on the autism spectrum is aggressive or will beat up other children, so we don't want them in our school, put them in a special setting, or they have mental health issues, they're never ever going to be able to learn. Those are all challenges to inclusion in education. Of course, we have the issues with lack of trained personnel. And when we're talking about training, it's not just a seminar or two. People go for a 2-day seminar, they go for a workshop, and they say, we have been trained. You haven't been trained. You cannot be doing the work and be saying that I've been trained. To be a special educator, you have to do 4 years, undergrad, then you go do a master's and specialize and all and then you're just coming in, you go for a seminar, GTB seminar, you say you're a special educator. You're not. You are just someone who is interested. And it's important that we begin to talk about training and competence and capacity building and the quality of our teaching. And of course, parental influence is a challenge. We've mentioned that already. And finally, I want to also say that we know that finance is an issue. But while we're doing that, we also must learn to put the needs of the individual first. Invest in database planning and implementation. Take data, take information so that you can share with other professionals. Invest in training, like I've said. Invest in resources that meets the individual needs of a child. So if you're taking a child that has language deficits, then you should start looking at resources that will work, maybe speech and language difficulties. You should start looking at investing, maybe picture exchange systems or augmentative systems. Don't just take the child in without looking at the resources you would need for the child. And of course, you need to create an enabling environment, school-wide support. Everyone has to be carried along. Everybody has to be taken to understand what it is to really, have an inclusive setting. And finally, parents must be involved in, the decision making. And when I say parents, not just the parents themselves. Thank you so much for having me. I think I'm finally done.
Thank you. I'm sorry, it feels like I'm rushing you.
It was, but that's fine. Thank you.
I did feel a bit uncomfortable trying to make you end. Look, can we all just clap for Mrs. Daisy? Like, let the chat section go on fire. Like, everybody. Mrs. Daisy, you have touched on, look, this is what we're going to do. I'm using the power vested in me to make this decision. We're going to move you to the panel session as well. You will join the panel session because there are issues that you have raised that we need to have conversations about. This isn't a monologue. And we told people that we're going to engage. And I think there are critical issues that you have touched on. But because I am running behind schedule at the moment, I won't be able to take all of those issues and questions now. So if you have posted anything in the chat section relating to Mrs. Daisy's presentation, please hold on to it. I will come to it. I know it needs to be addressed and we will address it. I promise you. I'm keeping her behind. There are conversations we need to have. You've spoken about, 4 practitioners. You've spoken about, the ecology, the ecocultural, aspect of taking a child in. But also, I want us not to look at this in one dimension. I want us to look at it in the practicality of our environment. I want us to look at, when we talk about this MDT, and that's one critical thing I'm hoping that we'll take out of here today. When we talk about MDT in schools and all of that, we cannot look at inclusive education outside the bigger context of education system in Nigeria. Now, schools in Lagos, for instance, are predominantly private owned, low cost primary schools. So when you start to talk about MDT, I hear you. It is as it should be. But reality, how do we deal with these things on the ground? Everyday reality, family income, family problems, finance, practitioners, professionals, all of these things. It's almost, it's a rough terrain to navigate. And so this is what I want us to come back and discuss. So please, Mrs. Daisy, don't go. I'm going to add you to the panel session, and we're going to have this conversation. Please just hold on to your questions. This is going to be lit. Can I just quickly call on Dr. Damilola? Sorry, yes, I got that right. Can I call on Mrs. Damilola? I think it's Dr., but Mrs. Damilola Banwo Oyalaja. She is going to talk about interprofessional collaboration required by the multidisciplinary method. So you have spoken about collaboration. She's going to come back and talk about collaboration some more, but please stay, don't go, unless you really have to, but please stay. Mrs. Damilola, over to you.
Hi, good morning. When I had Dr. Damilola, I was like, is that me? Because I'm not yet in doctor.
I've always looked at you as Dr. Damilola.
It's okay, but I'm not yet one. All right. So, okay. Yes, it's still morning. Good morning, everyone. I'm Damilola Banwo Oyalaja. Yes, good morning, Adela George. Good to see you all. And thank you, Lola, for this privilege, for this opportunity to share my thoughts and some of my experiences working in an inclusive school, over the years. So yes, just like Basireta said, I will be talking on, permit me to quickly share my slides. I think I sound a little raspy, am I?
We now have some background noise. We have background noise now.
Oh, okay.
Yes, that's gone. Yes, it is better.
Okay. All right, thank you. So yes, I will be talking on interprofessional collaboration required by the multidisciplinary method of approach. Now, this is quite dicey, but we'll go into it. And I like the fact that after the last speaker, Mrs. Jonathan, I'm sorry if I didn't get, I think I saw Jonathan. Yes, I like the fact that after she spoke, she touched a lot of things I would have brushed through myself, because I want to believe that by now we all know what autism is. So I'm not going to go into that at all. I'm trying to stay on time. So I'm going to be going straight into interprofessional collaboration, and how we achieve the multidisciplinary approach based on the fact that, in simple terms, how everyone comes on board, how everyone brings their hands on deck to ensure that the student or the learner with ASD is accessing learning and it is functioning maximally within the threshold of their strengths and weaknesses and abilities. So, and I like the fact that Basira touched the fact that how do we bring this home? Oftentimes I tell people when we go, we have these wonderful meetings and we talk about all of these different things. I ask them again, how then do we bring it to Nigeria? How then do we bring it to the African community? How then do we ensure that this fits into, the way it's done in the UK, the way it's done in the US? Oh, beautiful. But how do we bring this back to the African community to the end that our student in Nigeria are learning? So at that point, it's a little bit dicey because we want to uphold standards, but at the same time, we cannot overlook the fact that Nigerian community is quite different. So if learning is happening, we must, more importantly, we must ensure that our students are learning. Whilst upholding standard, we are ensuring that these students are still learning, and we are not losing them just in the bit of doing it the way other people are doing it. We are doing it the way it should be done. However, we are tailoring it to the needs of our community, to the kind of community we find ourselves, and to the needs of our students. All right, so this is just me in a nutshell, but I'll move on from that. Okay, so the multidisciplinary approach, which is also called interdisciplinary approach. Says this incorporates the use of information, data collected from different professionals across a variety of specialties and expertise to provide a comprehensive care and service delivery in an inclusive school. It allows the use of an integrated curriculum tailored to meet the needs of the student, meaning that this typically means that we are taking information from this professional. We have already identified, the weaknesses and the strength of the student. Usually, the multidisciplinary approach starts first of all with assessments, just like the last speaker said. It always starts with assessment. So we have identified that. We'll get onto that in later slides. How that we have identified all of this, and every professional is bringing information, is bringing all necessary information to the table, and then we are creating an integrated system of learning for the students involved. We're bringing all of this together to ensure that that student is basically learning. Now, the multidisciplinary team in relation to ASD, because this is why we are here, the Autism Awareness webinar. Now, in relation to ASD in an inclusive school, this is a team of professionals who have a common goal, however, are working hand in hand or collaboratively with other professionals for a purpose. And what is that purpose? Again, it is to ensure that there is a well-rounded student, a well-rounded, catered to student, a student who has support, all needed support, that has been identified as areas of challenge or areas of weaknesses, and the student is getting support in all of these areas. Now, a quick into ASD, what you would see in ASD, I'm not going to be explaining them. All other speakers have explained them. We see needs in area of social emotional aspect. We see needs in communication, we see social interaction, we see repetitive stereotyped behaviors, we see obsession with sameness, inflexibility, we see fixations on things, on items, we see hypo or hyperactivity or hypersensitivity or hyposensitivity to sensory input, we see sensory processing disorders. So who are the multidisciplinary team? And I'm glad that the last speaker has also touched on us. So when she was presenting, I'm like, she's already reading all my slides for me over there. So who are they in an inclusive school? We see them as educators, with subject teachers, general education teachers, the special education teachers. We see learning support assistants. In some schools, they call them teaching assistants. I think here in the US, they call them teaching assistants. In the UK, they call them LSAs. We see caregivers, guardians, and parents. We see school nurse. We see the school counselor. We see the behavior analyst, the therapist. We see the educational psychologist or the school psychologist. We see special professionals such as school-based occupational therapists, speech therapists, social workers, and the likes. We see all of those professionals work together to ensure that students. So just like Ms. Jonathan has said, when we talk about the MDT, we're talking about professionals who are aware of how the education system, when we talk about these professionals in the light of inclusion or in an inclusive school, they are aware of the educational system of or educational procedures and policies of that school. They are aware of government policies, educational policies. These are professionals who are aware on on different disorders, disabilities, or learning difficulties and disabilities that students may have in an inclusive school. These are professionals who are clear on their roles, expectations when it comes to inclusiveness or when it comes to inclusion in an inclusive school. So when these professionals, when we call them the MDT, we call them professionals who are working hand in hand to ensure that students are learning. And I like the fact that the other speaker talked about collaboration, which is a key word in my presentation today. You cannot achieve anything without collaboration. Even just the parent-teacher collaboration is as important as the child grasping and growing and learning in a school. You cannot achieve anything without collaboration. So MDT can only thrive when all professionals understand the power of collaboration, when all professionals understand the meaning of collaboration as a team. You cannot, the school psychologist or ed psych cannot achieve as much, or let me cite an example. I remember a couple of years ago working with a child in a school, and the parent, the teacher, the therapist, this is a child with autism, and this child was in grade one. This child was in grade one. However, the parent had not done an assessment for this child, even though it has been advised and this parent had been given a time frame, but this parent had not done an assessment for this child. Now, from observations, information, and all that, we found that this child has a therapist at home. This child has a private teacher at home. Now, this child comes to school, meets a therapist. This child is supported by the SEND department, but because it is an unofficial support, the parents are yet to do an assessment. But because the SEND department knows that there is a need with this child, they provide support for this child. Now, how can we achieve a holistic success if all these professionals are not collaborating? Now, from my explanation, all of these professionals are not collaborating. One, there hasn't been an assessment done. The therapist at home does not know what's going on in school. The private teacher at home does no relationship with the teacher in school. The teacher does not know what's going on in school. The parent seems to be a middle person here and there. Now, how can we call this team MDT, even though they are supposed to be called MDT, but they cannot achieve success? They cannot meet a common goal because there is no collaboration, because there hasn't been a common ground for which all of them have come together to identify a common goal, even though there appears to be a common goal, which is the success and the access to learning for that student. But how can we achieve that common goal if all are not on the same page, if all are not working together? So eventually, we had to call the parents. We said, you know what? You just have to do an assessment. You just have to get an assessment done. Get an assessment. That gives us that becomes the gateway for all of us to work together. That gives us a common platform to bring all of us together. And then, so the parent was eventually encouraged to go for an assessment. The assessment was done. And when the assessment done, we called a general meeting, of course. We told the parent, bring all those that work with the child. If you have a therapist, if you have this, we had all at the table, a round table meeting. We all had we all had a meeting, and after the meeting, we're able to identify what this is doing, what that is doing, and over time, we saw progress in that child. In that, when the parent comes, sometimes the parent will come, sometimes the home teacher will come, sometimes the therapist will come into school to pick up the child after school, and they discuss with all other professionals in the school. They meet the class teacher, they discuss. They meet the SEND department specialist working with the student. They discuss. So what is going on? Okay, what else would you like us to work on? What else would you like us to focus on? And that way we saw that we all were now working on the same page, and that child was now, it becomes a collaborative effort towards success for that child. So when we talk about MDT and there is no collaboration, it is not about the parent, it is not about the professional. The one who suffers it is the student, is that child. So when there is an MDT, then it should be done right. When there is MDT, then it should be handled right. If we say there is MDT and everyone is doing whatever they like, you think this child needs this person thinks that child needs that person thinks this child needs this, and everyone is now doing whatever they think without coming together to agree on, a process, to agree on an integrated system of support. How then can that child learn? All right, I don't want to keep going on that. All right, so we've seen the list. Now, all of these professionals, bringing it back to the African community, all of these professionals do not necessarily have to be physically present. However, we see schools work with all of these professionals in different forms, especially in forms of consultations and partnerships. You have schools who have partnerships with ed psychologists who they work with. The ed psychologist does not have to be inside the school premises, but it is someone they work with as a school, and they make referrals. You see that in partnerships, consultations, and referrals. You see schools work with social workers. You see, and these social workers do not necessarily have to be in the school physically, but they have collaborations that they make referrals back and forth. They get a report, and they know that I trust the report of this ed psychologist. I trust the report of this occupational therapist. I trust the report of this behavioral analyst. And we see all of this. You see but most schools in Nigeria that practice inclusive education and are trying to do so well. You see them have quite a number of them. Let me go back on that. You see them have quite a number of them. 1 minute. You see them have you see a school guide, a school counselor in the school. You see a school nurse. You see maybe a school-based OT or a speech therapist in the school, somewhere in the school. You see of course all others. But when we talk about specialized, like specialized professionals such as occupational therapists or physical therapists, depending on the needs of the child, or you see, or social workers or educational psychologists, you would, for such, you see, most schools would always work with collaborations, partnerships, and referrals, not necessarily having them in the school, but they have people, they partner with people they are trusted, they've used, and they keep referring their parents to because they trust the report from such ends. So, depending on the needs of the child, these professionals are present to support the needs. That's the way it should be done. Now, when I said that's the way it should be done, I mean that when we talk about the MDT, all of these professionals have to be on deck, have to be at arm's length. Ms. Lola, am I running out of time? Don't worry, I'm trying to rush, and I'm not saying so much because I want to believe everyone has said a lot, but we'll be.
So just to guide you, I would appreciate if you finish in about 6 minutes, so 11:45.
Okay, all right. Okay, thank you, Vasir. All right, so where was I? Okay, so they all are not physically present, but we see them in form of collaborations, we see them in form of partnerships and referrals. Okay. Now, interprofessional collaboration. How is this achieved? Now, the keyword there is interprofessional, and the keyword is collaboration. Interprofessional means different professionals. Now, the collaboration means working together. We all have a purpose. We all have a driving factor. We all have a goal to achieve. However, we are coming from different strength of expertise or different aspects of expertise, different areas of strength, different perspective of intervention to ensure that that student or that learner or that child with ASD in the inclusive school is accessing learning, is developing, and is improving on life skills. So different professionals, the occupational therapist will come from different aspects. The behavioral therapist will come in, to handle behavioral issues. We have the occupational also come in when it comes to sensory processing or sensory integration disorders. We see the counselor coming to, manage emotions, manage strengths, manage support and all that. We see psychologists do evaluations, reports, they continue to pay support and all that. So different professionals, you see the special education, how they bring the IEP, individual education plan, how they bring it to life to support the needs of the child. We see the general teacher who works with special education teacher to ensure that teaching and learning is happening, and this child's learning is following the set goal or the set integrated process of learning that are created for this child. We see parents and working in collaboration with the school, working in collaboration with all of these professionals, and ensuring that this child is developing and learning as well. So it starts with assessment and it continues with the same, meaning that before anything starts, we need to understand what are these challenges, what are these issues, what exactly are we dealing with, what are the presenting complaints, what are the presenting symptoms, what are the presenting areas of needs of this child. So there is an assessment, there is a report, and then we all sit together to create, to bring an integrated system of support and to bring it alive for this child's learning. Now, and I also added that it continues with assessment, because at every phase, depending on the school, I worked in a school where we do the SEND department would reassess at the end of every term. At the end of every term, you're checking progress. You're doing a internal assessment of the child. You go through the IEP again with the student. Has the student been able to go through this? You go through that. Has this student been able to achieve this? And then as this student, okay, so this child is still lacking in this. All right, so we are downgrading or we are upgrading, this IEP or downgrading this IEP based on the needs of the student. Oh, okay, no, we're moving on with the same. Oh, we're still continuing with this same IEP. We are not drafting. Oh, this child has met all the goals. So we are creating new goals. We are working with new targets now, more advanced targets, because don't forget, it's about the development. It's about a holistic growth of the students, not just about teaching and learning. That's what an inclusive school, that's what inclusion is about. It's not just about that child is just learning. No. Because if it is only learning we are addressing, then we don't need the behavior analyst, because one way or the other, behavior would affect learning. It doesn't mean that child cannot learn. It just means that there are comorbidities, there are all the militating factors that prevent learning from happening. You've seen a student who you take away these militating factors and you see the child become an A student, and you're wondering, this was a student you thought was just not able to learn. So just like the others, it's not about intellectual deficiencies. It's just that there are other factors that need to be addressed that would be affecting learning if they are not addressed. So behavior is part of it. Sensory is part of it. Maybe that child doesn't like the kind of light in the classroom. Maybe that light prevents that child. It distracts the child. Maybe that child is not able to process that lightning. Maybe that child is not able to grasp from that sitting position in the classroom. So all of these factors we consider when the MDT work with supporting the student, because when all of these are not addressed, then teaching and learning is affected. And it doesn't mean that child cannot learn. It just means that we just need to see all of the areas. All right, so oftentimes students with ASD would require more, of course, to ensure that learning and development is happening. And as such, collaboration of all stakeholders cannot be overemphasized. Just like I cited an example here. Now, my brain sends impulse or sends information to my body. Now, if my brain sends the information to my body and my body just decides, or my body is not willing to cooperate with my brain, can I function even as an individual? No, I cannot function properly. If my brain sends the information to my body, or my brain sends the information to my hand to touch something, and my hand is not touching, then I'm not functioning well. Same thing when we talk about the MDT. We all are working together to achieve a goal. We are not working individually, or I'm doing my own thing, and then no, we are working together. That's the power of the MDT. That's the power of the interprofessional collaboration. How that we all know what is expected of us, and we all are working to ensure that we meet the needs of the student. A quick example. I remember sometime I met a parent who had a parent with a female student at that time, and she reached out to me. She found out from someone somewhere that I was an occupational therapist, and then she reached out to me, and she said, "Oh, Ms. Dami, my daughter, she's having difficulty, this and this, this and that." I said, "You know what? I suspect this, but I would rather have you go for an assessment." Now, they did the assessment. It came out as dysgraphia. Now, before we realized it was dysgraphia, this child does not like to write. But this child can talk, she can talk, but she does not like to write. When it comes to writing, it's as though you are stressing her and you're giving her a huge responsibility. She doesn't like to. So I'm like, okay, if this child doesn't like to, before we identify the issues, I took the liberty. I met the teacher, which is what MDT is about. I met the class teacher and I said, you know what, this child doesn't like to write. Can you give her assignments in other, can she submit her assignments in other ways? Maybe an audio presentation or a video presentation, where instead of having to sit down and scribble, we are yet to identify why, but can she go ahead and she said, "Oh, no problem. Let her do videos of if it's an essay rather than write it, or maybe she gets someone to write it for her and she reads out, as a video presentation for me. I just need her to get the assignment." And that was how we got that child, the initial process before the assessment was done, we got that sorted out. Eventually, when it came out at dysgraphia, now, I had to bring on my occupational therapy skills and all that. And then we were able to, of course, it doesn't mean that you can cure it. It means that you can manage it, and we can look for compensatory strategies to ensure that this child is still learning. And, over time, it gets better and better. So that's the power, because all the fact that I did not choose to say, okay, just do video and submit to your teacher. No, I spoke with the parent. I spoke with the teacher. There was an understanding between the three of us, and then the student was able to make progress. So that is the power of collaboration. In the long run, it brings this student to success. It is not, if we do not collaborate, the student suffers. The development of that child is affected. The teaching and learning process, when it comes to that student understanding and grasping and and making success, is affected. So, having said that, so how do we achieve the collaborative success, and to what end? Don't worry, I'm rounding off now. I think this is the last slide. How do we achieve this collaborative success? Now, there is a common challenge, and that we identify at the initial phase of assessment. There is a common challenge, there is a common need. All of these are identified, after assessment has been done. We cannot do anything until an assessment has been done. And usually this assessment comes from all of this. For example, a child is referred to the occupational therapy department, occupational therapist. There is an occupational therapy assessment done. A clinical psychologist could refer for OT, or an ed psych could refer for OT. There is the special education recommendations after all of this. There is the OT recommendation in case there are needs when it comes to gross motor and all that, sensory integration. There is for behavior, if there are behavioral tendencies. So all of this, from the assessment reports, we are now able to say, oh, okay, so there is behavior. Oh, there is sensory processing. Oh, there is speech. Oh, there is there are different aspects. So all of these areas are identified at assessment, and from there, everyone has a role to play based on the understanding of the challenge and the need. An integrated system of support is set in place. Everyone is clear on roles, on obligations, and on service delivery. Student is catered to, goals are achieved, new goals are formulated, and the cycle continues over, again and again. And before you realize it, student is learning, parents are happy, teacher is achieving success, teacher is achieving targets, and child is developing. Thank you. Questions?
Thank you so much. So I'm waiting for the questions, but I'm not going to take them now. I'm going to just wait and take everything at the end. And I think the first thing that comes to mind for me is in the midst of all of this, perhaps we need to start reconsidering our approach to inclusive education as a whole. First of all, thank you for sharing the importance of collaboration, because we are all working towards meeting the needs of the child. And forgive me if you hear any background noise. I am not in a quiet space. Anyway, so the question is, do we need to change our approach to, how inclusive education should be practiced? Because at the end of the day, if I know a child has dysgraphia, has a label, and I have a child who cannot write or who doesn't like to write, doesn't have a label, perhaps we need to refocus to how do I help a child that cannot write, regardless of whether I know or not that the child has a label, particularly considering this context where it is so hard to get something like a dysgraphia, diagnosed. So these are things that, I want us to start thinking about. And when we're asking questions, I want us to ask questions, relating to how we can localize these things and take them to our classrooms, to the children that we're supporting in our different contexts. So let's go to the panel session. There's
a quick one on that before we go there. Now, this is an example. This was a training I went for some time. I was speaking at the training, and I remember, a professional like myself just walked up to me and said, "Oh, Dami, I have a student who, oh yes, it was also a student who doesn't like to write. Actually, he was also a student who doesn't like." I said, "Dami, what can we do?" I said, "It's as simple. I don't know what the problem is, and I can't know at this point because I do not see the child. But then, if that child does not like to write, let that child do videos, let that child draw, let that child do audio, let that child type." Some students do not like to write with their hands because of fine motor deficiencies or poor finger dexterity, or it comes even from distal joints to proximal joints, it comes all the way. And then because of whatever the challenge is, they do not. So however way it is, I like that if you try to find that we localize it. I'm big on localizing things when it comes to the African context or when it comes to students. How do we bring all of these big diagnoses? How do we just, okay, what exactly are the nitty-gritty of needs? What are those needs? How do we handle those individual needs? Not just the diagnosis. Yes, it's good to have the diagnosis. It's good to have an understanding of it. But in the absence of it, or whilst we are waiting for it, how do we meet those needs? It's just as simple as just improvising. And in occupational therapy, this is what we call clinical reasoning. Sitting down, analyzing that need, analyzing that problem, and clinically looking for ways to tackle it, how to solve that problem. For example, I have now this is off scene, but I have an adult with stroke. And this stroke, because of poor tone, muscle tone and all that, he's not able to grasp a spoon to eat, or he's not able to grasp a pen to eat. Now, what would be the first thing? How can he eat independently? Because the goal is independence. How can he eat independently, even within this threshold of the limitation? How? Now, I would now think of, I pad up the pen, or I pad up the spoon, I pad up the fork, and then I make it to the circumference the adult can reach. So that padding is reaching that circumference. So if I need to pad it so much, but it must just be enough for that parent to be able to hold based on the grasp circumference they can achieve. So it is improvising, it is sitting down and identifying those areas and then looking for ways to address those individual challenges. All right, thank you.
Thank you, Damilola. I know we're scheduled to have a toilet or a restroom break. Do we still want to take it, or should we just go into the next session? Host, what do you suggest?
Let's just take a little break and then we move on, because I think we've sat for more than an hour. So let's stretch, let's have a short video so we can how the brain learn. Mobility movement also helps. So let's practice what we preach. Thanks, everybody.
All right.
Well
I was about to swallow your break, but anyway, the host has said we should take a break. So 5 minutes break, or now it's 4 minutes according to my clock. 12 o'clock on the dot, we'll start the next session. All right, quick.
The demand for personal and professional development training is experiencing a boom, especially in the education space. Schools and related organizations are looking to provide their teachers or other staff with vital soft skills. Parents and educators are looking to build their own expertise, knowledge and confidence, as well as expanding their career opportunities. Teachers and special educators' engagement and performance can be significantly improved by the C.A.D.E.T Academy's effective personal and professional development training programs. Whether it's teaching strategies, behavior and classroom management strategies, or soft skills for educators, like collaboration with parents, confidence building and presentation skills, our online and offline course catalog can help you to create a flourishing work experience, drive career or business results, and retain your staff for the long term. Flexible, self-paced and easily accessible, our certificate courses are a cost-effective training solution allowing you or your staff to develop anytime, without geographical barriers. Invest in your greatest asset today. Invest in yourself and your staff. Get a certified training by the C.A.D.E.T Academy today. To learn more about the C.A.D.E.T Academy certificate courses, visit our website at www.cacademy.sch.ung/training. The C.A.D.E.T Academy is proud to introduce its inclusive school, catering to the educational needs of children of nursery to primary 6. In these days of uncertainties and moral decline, many children as young as below 10 are having to deal with the terrible influences of drugs, alcohol, sex, violence, unhealthy obsession with money, and other societal vices. No matter the religious or cultural background, most parents want their kids to grow with an understanding of godly truth about life. This is why the C.A.D.E.T Academy Inclusive School adopts the unique Alpha Christian Education ACE curriculum, which is founded on godly principles and has been utilized for more than 50 years, and currently in over 145 countries. The ACE curriculum is broken down into bite-sized colorful self-paced workbooks called PACES, which are carefully designed to develop thinking skills and create mastery and godly character in and out of the classroom. At the C.A.D.E.T Academy Inclusive School, your child will enjoy excellent mastery-based individualized learning, built-in reinforced system of learning, development of critical thinking skills, socialization, and godly character training. Enrollment of nursery to primary 6 pupils for admission into the C.A.D.E.T Academy Inclusive School begins on the 2nd of May 2022 for the academic session starting in September 2022. Register your child from 2nd to 30th May and get a 10% discount. To learn more about the C.A.D.E.T Academy Inclusive School and the ACE curriculum, visit our website at www.cacademy.sch.ung/inclusiveschool.
Hello, everyone. I know Dr. B, the moderator, had said we'll be back by 12. So, Dr. B, it's time. Where are you? Okay. I know we're meant to move straight to the, oh, she's having technical issues. I think our feelings she should get back. So we're meant to move straight away to the session where we have our panelists. So I'd like to invite everyone on the, I'm going to call out the names right now. She back? Okay, why she gets back. Thank you so much, Damola. That was an excellent, oh, she's back. Thank you. Over to you, Ms. Yes. Moderator.
I came in late. I couldn't help. I couldn't come in here. The last session of our police, judge, and Helen each and you however, what absolute of it. So
Dr. B, we can hardly hear you.
Inspects all right.
Hello, the reception is so bad. I can hardly hear you. Ahead, yeah, we can't hear you. I thought I was the only one, so.
Okay, while we wait for Dr. B to sort out the network issue, we all know what technology can do to us. So we're going to pretend that didn't happen, and we'll be optimistic that she's coming back full force. Coming back, she'll be back. So can we all hear me? I need an emoji. I need.
Yes, we can hear you.
Fantastic, fantastic. So we're going again to the next session, this next segment of this webinar, and we're having our panelists come up. We're having Coach Sam Obafemi. We're having Princess Wakego Ibrahim Pam. We're having Mrs. Idoma Ugu. We have Mr. Olatuji Solomon. We have Nana K. We have Adeomi Payne Akinomi and Mrs. Adelola George. Pardon me if I did not put a description to your name. You know I really honor and respect you all, and because of the friendship. So I'd like to have, in that order, I'd like to have each person introduce themselves. So I'd like to have Coach Sam, if you're online, please introduce yourself and briefly tell us what you do in the space of providing services to children with or individuals with autism in an inclusive setting or whatever setting it is, and the role you play. Could you please introduce yourself briefly?
Thank you, ladies and gentlemen. Hopefully my network is clear. I hope you can hear me.
Yes, I can hear you.
Can you hear me?
Oh, it's breaking.
Okay,
you might want to turn off your video.
So I
think your audio should suffice.
Okay.
I think you should turn off your video. Then
Can
Dr.
you
B
hear
is
me
back.
now?
Yes, much better. Dr. B, please take over. Thank you.
So can you hear me, or is text still messing
Much better now.
Much better now. Sorry, there's someone called Choma Lillian. Can the tech person mute that person? I think you can mute people that are not talking. That would help.
Hello?
Dr. B, are you there?
Can everyone hear me?
Loud and
Yes,
clear.
ma'am. Can you hear me?
Yes, we can.
Fantastic. So what I want us to do is, rather than do individual introductions, which will take about 3 minutes, and cumulatively, Coach Obafemi, please, 1 second. I'd rather we go through the overarching questions for the session, and then as you start to speak, you introduce yourself while you to the question. That we
Okay, I can barely hear Dr. B, so I don't know.
I can't hear her too. I can't hear her at all.
I'll take over again. So she wanted us to save time. Go on, Dr. B.
Can anyone hear me?
I can hear you. Go on.
Okay. Yeah, so I wanted us to save time. Okay, we can hear you clearly. Is it any better now? I've just switched networks again. Is it better now?
Yes.
Yes, it is.
Okay, fantastic. Yes. So I wanted us to save time. Rather than have individual introductions, I'll tell you what the overarching theme for this session is. And then whilst you speak, you can talk about what you do within the space. So for this session, we're guided by, 3 overarching questions. The first one is, what are the considerations when preparing and implementing IEPs for students with autism spectrum disorder in an inclusive school? The second question is, what are the considerations when working with families of children on the autism spectrum in an inclusive school? And the third question is, what are the considerations for children and young adults on the autism spectrum in terms of academic or vocational skills in an inclusive school? So these are the 3 areas that we want to focus our discussion. So when I call on you, you speak to any of these questions and then talk about your work and your role in the space. So Coach Obafemi, I'll take you first. Hello, Coach. Can you hear me? All right. Can anyone else hear me? So I know it's not me this time.
I can hear you. I can hear you. I can hear you.
Okay.
Yeah, it's not you this time.
So this time it's Coach. All right. In that case, can I have Adelola? Adelola, please, over to you. So you speak to those questions, and then you can tell us what you do in the process.
All right. Okay. I thought we were going to call Akion. All right. Let me get you straight. So the 3 questions are considerations in terms of IEP for in an inclusive school, consideration for parents in an inclusive school, and then the third one, I know I heard something about vocational skills for young adults, right?
Yes, academic or vocational skills in an inclusive school.
In an inclusive school. Okay.
For children and young adults.
I will speak in the Nigerian context, and then of course I haven't worked in an international school. So while we work in the Nigerian context, we also look at the British practice. First of all, what do I do? For like 12 years now, I've worked with children with autism and related disorders. First, I started off just working in centers, but over the years, I've been working with them as a specialist educator teaching them, supporting them in the classroom, and helping teachers to, general ed teachers to effectively teach these children and include them in their classroom setting. And please, I want to be sure that people are hearing me with all these issues that are happening. So if I say, oh, I can say some of thank you. So IEP, the honest truth is, the truth about including a child with special needs is that you look at several things. One, as everyone has talked about assessment, you look at what is the child's primary need, like what's the diagnosis, or what are the concerns. But much more importantly, you are looking at the child's peculiar needs and the skills that need to be developed. So because I mean, like other speakers have, like the speakers have said, autism is a spectrum, and it would express itself somehow differently in these children, when you meet them in the classroom. So I always tell that at the beginning of my career, I worked with children that were non-verbal, that were not saying anything, that couldn't communicate in any way. And so the focus at that time was we were working on building communication skills apart from teaching them. But at some point in my career, I worked with children who were very, very verbal, who were very vocal, so who can tell you their needs, but because they have autism, they definitely had struggles with engagement in the classroom. They had struggles with processing, receptive communication, understanding what the teacher was saying, or sometimes interestingly, attention enough to even listen to the teacher and get what the teacher was saying. So you look at the skills that are deficit in this child, and it's important for learning. I think that Lola talked about behavior, so if a child, for example, is not sitting in the classroom, I'm not even looking at early years, maybe like 2, 3, 4 years old, or if you're working with a 10-year-old, 7-year-old who is not sitting in the classroom, who is not paying attention, that will impact greatly on the learning. So I think that was great. And we also consider the general ed curriculum. What is this child supposed to learn in this class? Now understand that in that class, that child might not be, either because there are gaps, or sometimes having special needs means that the parents don't start off school at the time, maybe they don't manage the time, or the child is not identified on time, so the child misses out on learning early. And even if they are in school system and nobody's paying attention to them. So by the time you are recognizing that, oh, this child has autism, this child has gaps in their learning, and sometimes it's just deficit, that's why the child is not let go. You want to look at the general curriculum. What should this child be learning within that general? How do we differentiate effectively? This is how this child is learning. And I'll give an example. I think I've given the example like 1,000 times. Because this child has autism. I've worked with other children with other autism in school system. And this boy was on his learning age. I don't want to call his IQ in terms of a developmental age or mental age or something. But basically, what he could learn at that time was in year 4, but he couldn't be learning it. He wasn't at that level to learn year 4 work. But we could teach him. I mean, he had gotten to the point where year 2 was. So what did we do planning for him? We looked at year 2 curriculum, or the content of year 2 curriculum and the content in year 4 curriculum, and looked at how we could merge it. And we said to ourselves, what should this boy know in this level? What does he even need to know now, be able to progress to the next level? And one example I always give is the maths example. We knew that he needed to do no times table in terms of 2, 3, 4, 5, at least the 10, or the basics one, like 2, 10, 5, and then 3 and 4. So we put that in his IEP that if he can learn this one, then he can learn the rest over time. And by having this in IEP, the teacher was able to plan for him in her lessons effectively. So if she was teaching, I remember at that term, in a particular term, they were learning 3-digit numbers multiplied by 1-digit number. She made sure that every time she gave an example, there was always 3 or 4 in the questions. She didn't even have to call him, but the point is that boy was paying attention because definitely his numbers were there. The numbers he was working with were in the question, so he was paying attention. And of course, it also meant that she could call him because that was what he was learning, and he could engage better. Improving his engagement in class, improving his social skills, because now he's not feeling left out in the classroom. the other children are noticing him, and they are seeing that, oh, this boy actually has been learning, and including, and his social skill also improved, because then he was confident to relate with his class, because obviously he didn't want to isolate like we had assumed that he wanted to, right? So those are things that we look at in planning life. And for parents, to be honest, we want to pay attention to the fact that their emotions are important. First of all, getting a diagnosis for your child can be very difficult. So those are the things. And every session, parents are sitting in meetings with us, and it's almost like they're like, they started being hopeless. And so you want to constantly give them hope. Engaging them in IEP set meeting, getting to know what their own dreams and their goals for their child are, helps them that feeling of, okay, my voice matters, my child matters in this school and in this room. It gives them hope, and it makes them. In my own experience, really, it even improves on their own engagement with their child when it comes to academics. And all of this is also played out in what we're young adults, because you're looking at a 3-year-old, a 5-year-old, a 18 years old. Autism is a lifelong disorder. And so there's always that transition plan. One, even in planning the IEP and general engagement over time, you are constantly helping that child transit to the next level and teaching that child how to transit, even someone on their own, build transition skills, working with the parents, working with the child. So by the time they're in secondary school, what are the new goals? The goals kind of change from just being academic and just basic social. You're looking at only, you're looking at maturity and fitting into a setting and helping them. So, and really, inclusive schools, and they talk about vocational skills. Often they talk about it like, this child not learn, let's tell the vocational skills. But the honest truth is, whatever we are doing, whether it's academic or vocational, we should know that we are building an independent adult. And what is successful, regardless of disorder. I understand, like Jonathan even mentioned, some children with autism will have their profound level of difficulties and all of that. So that is also put in place. Okay, how is this child independent in a way? But because what about speech? If a child cannot talk, are you saying that child should be completely dependent on others all through their life? Should the child not learn? Those are the things that we're looking at, and that's part of. A lot of things have been said about communications. So I just wanted to keep that in. But that's also part of the plan. How to make sure this child is not talking. I've worked with non-verbal children in mainstream school, and I know non-vocal children in mainstream school, and you know that you have to make sure that that child is constantly learning to communicate and label with or without words.
Thank you, Adelola. So you've touched on a number of things, giving parents hope and also trying to merge, what a child knows versus what you think that they should know. And so Adewumi, I am coming to you next. You in your role as a Senko, what are the considerations that you find when trying to make something like this happen? Move a child from what they know to what you think they should know. Where does what a child has capacity to do, where does that come in? And how do you manage this with the parents? Can you tell us in about 10 minutes?
So good afternoon, everyone. Good afternoon, nice to be here. Good afternoon, all my learned colleagues that are here. Let me just do that as in one shot. Okay, the question you asked me is on the area of family and then expectations, right? Okay.
Yes.
All right.
Yes.
Okay. The first thing with parents, you see, I've been a special needs coordinator for about 14 years now, and I've met quite a number of parents. And in recent years, I'm working more with schools, not only with a particular school. So what I will say about expectations is this. There are two types of parents you will meet. Some parents who are in denial totally. And they will tell you, and look, it's not about, Nigeria has its own peculiar thing, but it's not only about Nigeria. I've been very lucky in my career to have been to about 5 continents of this world, and I've been able to go into classrooms, talk to parents, train teachers, So I can tell you, Oha, that there's a group of parents who feel, no, my child doesn't have anything, and they don't believe it. And they want to just pretend it's not existing. And there are a group of parents who accept there's a need. But in their acceptance, they choose what area of the autism they believe their children have. So Dr. Daisy said something about that earlier on in the morning, that, you have a child that looking at that child, I'm not being derogative. This child is just capable of study, maybe do some things in arts, and then be able to defend his artwork. And then, our aim at the end of all special needs support is independent living, like Adelola said, so that they grow up and be independent, especially if the severity of the autism is not going to inhibit them living an independent life, so to say. So parents who should just support that child through school, if the child can go through school, or support that child through vocational, so that the child grows to be an independent person and can live on his own, in quotes. I've met autistic people who are married males, and their mothers live with them. The wife understands, just to support them, and they're living well. But then these parents will tell you, I want my child to be a medical doctor, because they said when a child has autism, that child is gifted. Dr. Daisy mentioned it. It's not all the children with on the autistic spectrum that are gifted like that. So when they start telling you my child is gifted, I see an engineer, I see a space engineer, you need to bring parents on the page. You see, it's not going to happen in a day or a week or 2 weeks. But you see, you need to bring parents to the point where you are all on the same page. And that's why IEP is really, really fantastic. You look, daddy, mommy, I'm a Christian too, I'm a Muslim too, I believe God. But you see, let's work with what we have now. He will be an engineer maybe in the future, but now, this child cannot handle physics. This child cannot handle this. Let's just handle math, English, and then let the child explore arts, explore ICT, explore music, try PE, do all those other things that can lead to a vocation. You understand me? And then if we now realize that, all of a sudden, he's now doing well in math and things, it's the school. And if it's an inclusive school, we come back on the drawing board, everybody working with the child. I'm so happy with all the people that have spoken today, because they even made us realize that every area of this special needs, everybody has their own peculiarity. I'm a special needs consultant, coordinator. I'm not an occupational therapist. I'm not a speech and language therapist. But all of us have our positions and our areas when we gather to support a child. And when we are providing support, if speech is not an issue, because I wanted to say that, to go back to the fact that autism is a triad need, and it comes in different flavors. Pardon me, I love to say flavors. I think it sinks into our Nigerian minds. When you say flavors, it could be more of communication as need, and then less on social skills and less on behavior. Some children, like Adelola said, they speak well. They don't have challenges with communication like that, but their social and behavioral needs are heightened. So it's a triad need that can come in different flavors, and it could be comorbid. A child can have ADHD with it, can have dyslexia with it. I've seen a child who is autistic, who is living with autism and living with Down syndrome at the same time. So we need to know our positions and then try to get parents on our page. It won't happen in a day. It won't happen in 3 weeks. You see, some of these children are male, and you know the way we Africans see male children. And then the mom wants a doctor, because what will I tell my husband's family and things like that. But at the same time, bring them to your page. If this child is gifted, my cousin graduated with math in the uni, and he's autistic, but there's some children that will not finish school. So when we get parents on our page, then the support can start. Research has shown that when parents are involved in their children's learning, in the children's schooling, success is miraculous. So what I tell parents is that I believe in miracles. And I'm sure all of us here believe in miracles. But you see, miracles happen more for parents who put hard work into it. For parents who agree that, look, this is my child's need. This is an area of strength. This is where we can pursue, and allow external, all these professionals that are here to support them. in helping their child achieve independence at the end of the day. Have I been able to answer your question?
Thank you. I think this will take me to the next speaker. And so, because one of the beautiful yet complicated things when we're having these conversations is you will see the interconnectedness, right, of everything that we're saying. You will see that there's no straight line. You know, you can't just, please help us mute. So you would notice that you can't just follow a straight path. And as you're talking about one thing, you need to bring in other things. So at this point, I'm going to bring in Nana. And Nana, I want you to speak to, so we're speaking about, you know, how important IEPs are and how important it is to bring parents, right, to the same page as the professionals, how important it is to set realistic goals and manage their expectations. Nana, you understand, you know, the whole concept of supporting children one-on-one to help the behavior and things. I want to ask you, how do we in Nigeria manage supporting children in schools where parents don't want to go with label? We understand the multidisciplinary approach, yes, but how can we still support children, you know, when the parents don't want to go with the labels? And also, how do we cascade this support where there is an evident gap, you know, in the parents' knowledge? Adewumi has said something very, very important. There's a positive correlation between parents' involvement and children's outcome. We found that. But where parents don't even have the knowledge, how can we do this? So let's bring this home. Labeling and parents not having the knowledge to support these children, and so makes it difficult. How do we deal with this?
Okay, can everyone hear me? Okay, good afternoon, and I'm very cognizant of the time. So Lola, Mrs. Lola and Dr. B, thank you so much for this. And I'd like to say good afternoon to everyone here. It's been so informative and I'm learning so much, I must say. And I'm going to try and be as fast as possible because I know this is the time is running. First and foremost, my name is Helen Nana Akwinakwe, and I'm actually a lecturer in early childhood care and education in one of the universities in the Republic of Ireland. I lecture particularly in the area of early intervention. So I have 2 degrees, linguistics and early childhood care and education, and then I have a master's in applied behavioral analysis. So I bring in a lot of experiential learning into the classroom to my students who are training to become teachers, both for neurotypical children and neurodiverse children. So based on the question that Dr. B has asked, I would like to say particularly that when it comes to children and labels, you see, I believe that, so my first degree is from University of Benin, so I'm not talking as if like somebody who doesn't understand how the system works in Nigeria, just to put that out there. So I know that lots of times, while we love labels and titles, we don't like labels that sound like they are negative, right? So I think that negativity is usually the problem. When maybe people say, oh, you know, go for assessments, go and check your child and, you know, get a proper assessment for that child. Now, the beauty of getting a proper assessment for the child, just like everybody has said, from Mrs. Daisy to the doctor to, you know, everyone else, is actually knowing how to best support that child through, you know, from early intervention up to when the child is, or the individual becomes independent enough to live independently within the society, because at the end of the day, that's the aim, and that's what we are aiming for. Dr. B, how many minutes do I have, please? Because I'm so...
Take about 5 minutes, and so
oh my goodness.
We can still go another round because
okay.
The questions. So we'll still go another round.
Okay, so basically that's what we're looking at the end of the day. So usually, as someone who works with parents, and I always say that to my students, that there's something we call effective communication skills. And it is one of the topics we deal with in the early years. It's part of one of the topics I deal with in one of the models that I do. And it's all about knowing how to talk to parents so that they understand the need, the importance, and the fact that you are not labeling that child. And I think the reason why we are so particular about these labels is, sometimes you hear things like, Olodonye, I don't know if I'm right, but things like that. And that makes, if it's your child, you feel hurt, right? But if we're able to let parents see the reasons why we get this assessment, that it's not for labeling, but for them to get the proper kind of, supports that they need. So autism is, there are 3 severity levels. And based on each severity level, you then think about the kind of intervention strategies that you put in for that child or that individual. So if you don't get a proper assessment to know the level at which that child falls, or that spectrum where the child falls, then it becomes difficult to provide supports for the child. So with the labels, really, it's about how you effectively communicate with the parent and to bring to the fact that emotional intelligence is so important, because like they say, if you meet one child with autism, you've met one child with autism. So it's important that you're understanding the culture of that person or that individual. I teach that in class all the time with my students, and I tell them cultural awareness is key. It's very, very important, for you to understand where that person is coming from. Even the social class of that individual, is so important. The family that child belongs to, it helps you to know how to effectively communicate these to the parents. Then, in terms of the evidence-based gaps, oh my God, the whole idea is that, for example, in applied behavior analysis, for you to become a board certified behavior analyst, you need to constantly keep yourself abreast with the literature and journal articles, not only in that space, but in the space of your area of specialty. So, for example, I deal in the area of early intervention for across impaired children who are visually impaired, Down syndrome, cerebral palsy, and all that. But let's bring it to autism. I need to make sure that I'm keeping myself abreast with the journal article, with the literature in the place, knowing how to use the DSM-5, knowing how to actually understand what is needed and how I explain things to parents. So when we talk about this evidence-based, basically, I'm sure a lot of people know, but for those who maybe might not really know what it is, it's evidence-based means that it has had that scientific what's it called, the scientific because I'm rushing, I've kind of lost my thoughts. So you've had that scientific research, thank you. And over time, we have seen that these strategies or this particular method of doing things works. And so that's what evidence-based is. So we just need to make sure that we're encouraging parents to read, encouraging educators to read, encouraging administrators of schools to read as well, so that they keep themselves abreast and so that they make sure that they are pushing out that information and making sure that when people come to them or parents come to them, parents get the right information and things that are abreast with what it is that they need to know in terms of their children. I've rushed this thing so much, but I hope I've answered that question, Basiwat.
Yes, you have. And I like the way this is leading to every other question that I want to ask, because each speaker touches on something that is integral to the overarching questions. And then that leads me to, how to bring in the next speaker. And so, Coach Sam, I'm going to come to you next. Nana has mentioned, how the importance of culture when we're communicating. And as we found, a lot of parents, want their children. It's just, you want meaningful life for your children, whether you're alive or when you're gone, regardless of how their impairment or how they may be disabled by the environment. And so what do you think are the considerations, Coach Sam, when we start to look at these children and preparing them for adulthood in terms of autism spectrum? What are the considerations, for academic or vocational skills in an inclusive school?
Thank you very much, Dr. B. Thank you, Lola, C.A.D.E.T Academy, and everyone. My name is Sam Obafemi, and I work for SOPCA, Sam Obafemi Behavioral Change Academy in Abuja, where we provide mental and emotional interventions for everyone, really. We have a system where, so first and foremost, my background is not in the field of neuroscience and all the works. My background is computer science, But over the last 18 years, I've been very enthusiastic and interested in this work. So I've developed myself in professional learning over the last 18 years to be able to provide mental health, first aid, to provide positive psychiatry and positive psychology. And I run a system where we work with clinical psychologists and psychiatrists to provide interventions for people that are going through any spectrum of mental health or special needs. We do a lot of collaborations with Lola and the C.A.D.E.T team in terms of referrals and exchange. One of the speakers earlier spoke about referrals, and it's been a very rewarding relationship. Talking about culture and how it affects, the delivery of intervention for problems around special needs. I think that we still have a huge gap because of the background where we are coming from. To a large extent, many of our families and our loved ones still do not understand the science around special needs challenges. They still do not understand the fact that some of these challenges can be either genetic or can be biological, from environmental issues, can even be from relational issues. And so we still have this dichotomy that affects the ability for families to embrace the need to help their children. I particularly liked a statement made by one of our speakers, I wish I can remember, and I think Dr. Daisy, who said, when you notice your child is slow at any developmental stage, you should be proactive. And these are some of the realities that parents and our environment, our society must begin to look at. I think that we need to develop more commitment. We in this community, we must develop more commitment to provide more information. If you agree with me, culture actually is dependent on the level of information available to people to a large extent. Because if we look at the transition of so many philosophies and ideologies going on today in the society, in the whole world, there is a lot of information being pushed out that is getting people to change how they used to think about different things. And we must see that if we're going to succeed with tweaking and improving on the culture of our society as they look at special needs related conversations, then we have to embrace a lot of communication and information sharing. Some of the challenges I have noticed with all of us who are interested in behavioral change is that we're working in silos and we're working in our own spaces. We seem to just say, I'm doing my thing where I am. And I can tell you categorically that it has not been really helpful in the long run. If you look at the big picture, it has not really helped. In fact, I'm happy that we're talking about multidisciplinary teams and collaborative work across different specializations, because the more we begin to see that no person in this call has the singular authority and singular resourcefulness to solve every special needs problem, the more we see that our collaborative work is very critical. And then we have to now embrace the need to communicate as much as possible what we do to the layman on the street. If you ask the average parent what some of these spectrums are, they have no idea. If you ask the average families what they understand about anything we're talking of autism spectrum, we're talking of Down syndrome, we're talking of speech therapies, we're talking of first mental health, behavioral CBT, the average families really don't understand what we're saying. All they know is that this child is not fine, and they don't even understand why the child is not fine. And we also don't have the native local language to explain the information development and information sharing is very critical to develop and to enhance the culture that currently governs how we provide interventions in this area, especially for special needs and autism, as far as we speak. My mentor said something. I'm going to say this as my last comment. My mentor is a vet doctor. He's an experienced vet doctor, a very big expert. He runs a lot of projects for the federal government. And one day he said that he has noticed the reason why vet doctors are poor, and the reason why vet doctors are not able to successfully provide vet services to the owners of pets. And he said, vet doctors are trained to communicate with animals. They are trained to speak animal language. They are trained to observe animals, but they are not trained to human being that we pay you. So, context, it means that we.
Yes, you're back. We can hear you. It keeps breaking.
Oh, okay. So, if I adapt that analogy here, it means that, so if I were to adapt that analogy, very, learned, very exposed, very educated, very, experienced in this field that we have chosen as psychologists and all the works. But we need to remember that the average parent who is paying for their child's intervention does not understand our jargon that will help parents and families. We must start understanding the language we can speak to parents and get them to understand that their child will be better. Sometimes parents think that we're just trying to deceive them by calming their frail nerves. So we're speaking positive words and telling them, no, your child will be fine. I saw someone in the chat room say, we normally tell them that Bill Gates is autistic and so they can have hopes. This sounds nice. This sounds great. But the truth is that many parents may feel that they are saying these things so that we can feel calm. They are saying these things because they want us to pay them. We need to understand how to speak to parents so that they can understand the science behind the solution we're providing, and they can see for themselves how to get involved in helping their own child. By doing this, we can influence the culture of the work we are doing. So I just want to encourage every one of us here, don't be fixated on your professional learning, and don't be fixated on your, our category and sectors of learning and all the big grammar around the jargons that we do, which has become like part of our, somehow it's like it shows that I'm very professional. We need to keep it simple and short. KISS, KISS principle. We need to learn the language that the average layman on the street can understand, so that even if they don't come to us, they themselves can see that, okay, if I do this and I do this, I can manage this child and this child can become better over time. With this kind of understanding and communication, we can tilt the culture over time. Thank you very much.
Thank you, Coach Sam. Princess Wakego, I'm coming next to you. So in your role, how do you find the contribution of speech therapy to the production of an IEP, or in fact towards preparing a child for academic or vocational, skills in the future? What is the role that speech therapy plays in all of this? Do I have Princess?
Okay.
Can you hear me? Yes.
Thank you very much. Good evening, everyone from South Korea. Thank you, Lola, for organizing such a very educative and highly impactful seminar. Like I would like to say, when I started being a special needs teacher and a speech therapist, that was some 29 years ago in Nigeria. We were very few, and there weren't any structures for us to follow. But because of my exposure then, I went to Israel to specialize in early childhood education and parental involvement. and I was exposed to the different kinds of centers that they had there in 1997. So when I came back from my postgraduate studies from Israel, my mindset just changed. I had a totally different view of how to handle the special needs child, or what an inclusive education meant for special needs children. But before I go on, I would like to answer your question from the question that was first asked, and I think the second speaker answered, but I just felt I needed to add one or two things, and then I would connect it to the IEPs, to the parental involvement, and then to the vocational training. I paraphrased the question, which said, why do we want to make the special needs child act as we do normally? And I said, there are three major reasons for that. It is the demand of society to conform to the acceptable societal behavior. The total lack of awareness and appreciation of what the children are going through emotionally, physically, mentally, and socially by their parents before even the society. And then, thirdly, a lot of parents are ashamed of their children's behavior because society has stigmatized them as rude and non-conformist. So they are, even before we knew what is wrong with them, they've already been labeled as outcasts. Oh, these rude children, they just shout anyhow. The mothers don't know how to control them. No good home training. Totally oblivious of where these children are, where they're coming from, and the various variables that affect them and why they are behaving the way they are behaving. So I've been a special needs teacher and a speech therapist for over 29 years in 6 continents, in different cultures and different languages. I have discovered that the key to reaching parents is having a historic background of the families. And that takes us back to culture. As a professional, you do not attend to a child without knowing first the variables that nurture or forms the child. That is the basic element. It's called the early practices of early childhood bearing. What are the things that are secure base for this child? And those things come in cultural context. It comes in language. Language is very important to a child. I see so many children struggling with early intervention because we do not speak the same language. I've had children who speak French brought to me, an English speaker, to try and do speech therapies with them that is changing. Not only they're already emotionally and mentally incapable of understanding what is happening around them, now you want them to change even their language of communication, adding more pressure to the child. So culture, as a speech therapist, I have learned, before I take on any child, I do a cultural research, background research on the family itself. I have a form I send to the parents, and they tell me everything about the child, and from the point of view how they see the child. And the second step is I don't take any child on except they have gone through the medical checks. Because if you don't have those medical assessments done for you, as a speech therapist, you're working on an assumed premise. You do not have any scientific assessment that will guide you in forming your IEPs or having to interact with the parents. So the first thing I do is to have trainings for the mothers, especially for the mothers. The men are very difficult because already the child is causing a marital strife between the man and the woman. The man wants to say, no, this is not my child, it's only your child, so take care of it. So I always have to deal with the women. So the first thing I do with the mothers is to train them, to create that awareness, to teach them. I like what the last coach said about making it simple. Speak the language of the parents.
The parents are too afraid when we use medical terms or professional terms just to impress them that we're experts in our areas. They don't need to know that we're experts in our area. They need to feel that compassion. They need to feel that we understand the pain, the emotional pain they're going through. So it's our duty, for me as a speech therapist and an early childhood educator, to make the parents see reason from her own point of view, not mine. And once they're able to assess the child from their own point of view, then you've won them over. And as a speech therapist, I like what the last, not the last speaker, Helen, I think is her name. I have developed an IEP from evidence-based theories. I have journals of every child that have come through my center. And through those journals, I develop, because I've seen it. I've seen Down syndrome children. I've seen hearing impaired children. I've seen autistic children. I know the different aspects of autism and how to deal with them. I operate an inclusive center where I collaborate with professionals in all the fields. And because of that, we're able to have scientific results of how we can deal with these children during the period of time they're going to be with us. But why? Now, let me go to Nigeria. The problems that are existing in Nigeria is not just based on that we don't have enough qualified personnel. We do not have the structure. The institutions are not there to help safeguard our practices, to help define areas of ethical practices. Like the coach said, we're all on our own, everybody trying reputational protection. And because of reputational protection, we do not collaborate. Oh, let me not share what I know with this person. Oh, they'll soon go and say, no, we have to be collaborative. Once we're collaborative, then everybody becomes specialists in their own area. And then this child is taken care of in a holistic manner. But that do not happen in Nigeria because of one professional greed. No, I don't want any other person to make the money. And that is why you see the inclusive schools in Nigeria, they handle everything to everything. That is the first step to doom. It's wrong. It's not acceptable. In the different countries that I live, inclusive schools define what they are dealing with so that they can, you're talking about a multidisciplinary team. It's so expensive. No one school can afford it. Even no one government can afford it. That is why it has been structured in such a way where it is staggered in such a way that each child is exposed to each of these different specialist programs at a different stage, so that financially, otherwise, the family is not overwhelmed. Neither is the social security system that is available in Western world overburdened with such demands. But in Nigeria, we do not collaborate because of fear of people stealing our ideas, instead of fear, the greed of making more money. And we just, like somebody said, take the titles that do not belong to us. We do it all just because we want to keep the money within our schools. Until we get to the point where schools decide, I will only be specialized in this area. And then they will have the capacity, they will have the manpower to be able to provide the multidisciplinary team that the children they have taken on can benefit from. And inclusive centers should have a number of children they can take care of at a specific time, so that you have a timeline. If this child stays with me for 6, I usually have a waiting list in my inclusive center. I don't take more than I can chew, because as a speech therapist, I work 40 hours. And I start from 8 a.m. in the morning and I end by 7 p.m. in the evening. And that is not enough time, because for each child to be clinically taken care of, at least they need 18 hours a month or 7.5 hours a month. And that is depending on the severity of the child who has this language or speech problems. I also deal with hearing impairment, because I need to prepare them clinically for their schools, the positions they have to sit, what distance they need from the teacher, what aspect of the head position they have to sit in class. So being a speech therapist for over 3 decades, I've come to understand that we need honesty. Somebody talked about ethical professionalism. We lack that in Nigeria. We do not put effort into achieving that holistic result for the child. We put more effort in reputational image, generating income, giving the impression that we know it all. Until as inclusive schools, we are ready to admit that we're only going to do speech and language therapy or physical therapy, or we're going to do behavioral and social skills, or then we will just be messing up a lot of families financially first, and then emotionally for the children. When you talk about vocational needs of the children, it starts from when they're very young. Because for a special needs child, for you to go into any vocational field, it must be something, one, that the child likes. It must be something that the child understands and is capable of doing. And it's also something that the parents can help the child with. So when we talk about special needs children, it's a holistic level of collaboration. First, the collaboration starts from the family, which is psycho-educational intervention. You have to educate the family about the needs of this special needs child. If the family understands the needs of this child, they are the source of, they are the tools that will translate the needs of these children to the larger society where the children interact with. But most parents or most families are not equipped. They do not know what to do to help their children. So these children are exposed to society or professionals like us who use our experts or our knowledge to either manipulate them for our own financial gains or manipulate them for our own professional gains, so that we will say we have gone through 300 children, or we have done this, we have done that, at the expense of his family. So I want to round up that. Okay, go ahead. Thank you very much.
Honestly, you said something that, and a comment just came into the chat section, that a multidisciplinary team may not be affordable in our client, but a multidisciplinary approach is doable. And I think if you don't take anything away from here today, I think everyone needs to go away with that. A multidisciplinary team might not be attainable, but that approach is doable. And I hear a lot of people talking about collaboration. Look, I am on the field and I'm talking to parents. And one thing I've heard repeatedly is parents telling me that they have worked with professionals, without naming names, right? That they have worked with professionals in this field, or well, supposed professionals who, when they meet you, make you feel like they are the one and all to solve your problem. So they want to be your OT, they want to be your salt, they want to be your everything, without making them realize that this multidisciplinary approach is what they need. And so they find out that that professional cannot deliver on anything. And by this time, a lot of time has been spent, a lot of money has also been spent. So thank you very much. Again, it feels like I'm rushing, where we are going over time, but I ask you to please be patient. I'm going to try and get everyone to speak, and I'm going to take as many questions as possible. My goal is to finish in another 15 minutes. So please, if you can spare that, please just work with me. So I'm coming to you, Ijeoma. What can you say to the role of collaboration, in preparing children and young adults for academic and vocational skills in an inclusive school? What can you say to this, Ijeoma?
Thank you, Doctor. The whole
5
discussion.
minutes. 5 minutes.
It's been quite intriguing. I've learned a lot. I've heard a lot. I am Ijeoma Ugu. I am a human nutritionist, a certified bio-individual nutritionist. I work with children with neurological impairments. And talking about collaboration, we were just discussing on the chat room. We've seen a lot of times when one person just claims to be everything. So I want to thank Mrs. Daisy for bringing this up, because we need to collaborate a lot. I am a parent myself, and I've seen a lot of times when one person would want to offer everything. For a long time, when I have a client send in inquiry, I would like to fix like 5 to 10 minutes meeting just to understand your expectations and your peculiar challenges and your expectations. And in that meeting, I tried to let the parents know that as a nutritionist, I am not going to cure your son. I am only providing a nutritional support. And nutrition works from the inside, while other therapies are supposed to work from the outside. And let us hope that they meet at a point to make the child whole again, or even not whole again, at least functional. So what I tell parents, what I tell fellow colleagues and professionals is, please try as much as possible to stick to what you can do. I was just writing on the chat that on a good day, on an ideal situation, a speech therapist should not be able to steal a client from an occupational therapist or even an ABA professional, because you don't do the same thing. You don't offer the same services. So why should you be able to steal a client? And being ethical is one thing, and being disciplined is another thing, because you may think you know it all, but please don't delve into what you do not know. Give it to another person, even if you have an idea of what it is about. Give it to them and make the parents understand what you can and what you cannot do. First of all, it will start to even build their confidence in you. They will understand that at least you know where your line, you can draw a line to where you can stop. And as a parent, I found this necessary because so many times as healthcare professionals, on the psychological aspects of it, a parent is going to a healthcare professional with the hope that once I do this, it's going to bring all my troubles to an end. But that is usually not the case with us when it comes to children with neurological impairments, because their challenges are multifaceted. It is not just one thing that ails them. There are comorbidities and there are different phases of challenges. It is not the same challenge that a child faces when he's 7 years old and he faces when he's 10 years old. And that's not the same challenge he faces when he's 13 years old. So I would advise professionals to always try and stick to what you can do and give it your best shot. And when it comes to collaboration, yes, a lot of factors are preventing us from collaborating, and those are more or less just societal factors. People feel they are superior. We have this tendency of thinking that it's only when we match the other person down that we can step up. But that shouldn't be. What should be is that when you want to go far, you work together. When we work together, when I'm speaking with the neurologist, I've had cases where institutions bring me in to be a part of assessment. And that is what I would want to do. I wouldn't want to be the only person catering for a child. Even my own child has therapists, even when I am a nutritionist. So I wouldn't want to be a sole provider of a service to a child. I would want to work with someone. I have a neurologist I work with. I have academic institutions I work with, because nutrition fortunately covers all areas, because what you put in is what you bring out, as it is said. And I want to also ask us, a lot of sciences are coming up. Education is all about learning and unlearning and relearning. Let us not just fixate ourselves on the things we learned while we are in the university. Someone has mentioned it. Keep updating yourself. Keep updating yourself. There's hardly any point in time I am not taking a course somewhere else. Some people think I'm crazy. I'm always doing one course or the other. So let us keep updating ourselves. Let us let go of that restriction we have when it comes to collaborating. Sometimes people think you are hoarding information. That is also an aspect I want to come in. People think you are hoarding information. No, you are not hoarding information. You are trying to follow like a procedure. Okay, let me just give an example. Before you can get up and recommend a diet plan for a child, you need to know a lot of things. You need to know the medical history of the child. Like me, like Sister Nwakego mentioned, Mrs. Nwakego mentioned, if you come to me, you need to have a medical evaluation. I need to know what goes inside of you before I can offer something else that I want to put inside of you. You need to have a medical evaluation for me to have a direction of what I want to do for you and with you. So when we are saying, please, I need to know this and this and this before I can offer a suggestion or even a recommendation. Don't see it as me hoarding information. And I say this about other professionals. A lot of times when we think we are hoarding information, it's not just because you don't want people to know what you are doing. It is because you need to have a direct information about what is happening, because what is applicable to some persons may not be applicable to some other persons. So even parents, sometimes we just dish out, okay, when I'm talking about my area, which is food, some parents will just come and say, okay, my son, this is our meal plan. Can you ask the person, how did you arrive at this meal plan? They probably arrived at that meal plan using a medical test on the food allergy, or even organic acid test, whereby you find out that the child may have some hidden challenges, maybe digestive problems or inborn errors of digestion, or even a nutrition malabsorption or something that might have made someone draw out that kind of plan for such a child. So when we talk about collaboration, it's all about making sure that you are covering all areas, providing direct, how do I put it, direct support for the direct problem. In my present duties, I visit doctors, I visit nurses, I visit practically healthcare professionals. And what I'm coming to realize is that, like, a huge number of them, pardon me, Dr. Izua, but a huge number of doctors and nurses actually not conversant with what is ailing us. So when the speaker was talking about doctors asking parents to wait for a year or 2 or 3, I say, please do not wait. When a doctor tells you wait, please don't wait. As a parent, you know best what is ailing your child. And early intervention is always the key. Early intervention can actually go a long way to prevent a lot of things. By getting it right early, when I talk about food, when we were going to ask about vocational skills, I budgeted that to be for adults. So when we talk about food, if you have trained a child that this particular food is not right for you, that child, even at 12, 13, even when he leaves your home, would have understood that this is the reason why you said I should not eat this food. And that child would have noticed that whenever he eats that food, he does not feel all right with that food. But if you did not start early, a parent approached me yesterday that his son is 20-something and he drinks beer and he's asking me to help. And I'm like, at this stage, it's very difficult to begin to condition a man and say, don't have this. So early intervention, the aspect I'm taking now is that early intervention goes a long way to curtail a lot of things. So on my area, I say, as early as possible, approach the professionals and work together in the multi-professional team, get to know what every one of them is all about and what every one of them can offer you. And I know it's expensive. I am in it too. It's expensive, but we've come a long way. We all also understand how expensive it is. And if you pay close attention in each of the consultation, I'm sure as a parent, you should be able to pick a lot of things you can implement on your own, even without coming back to meet such a person. For me, like when I go to a consultation with parents, I teach you how to make something like a bone broth. I teach you how to make something like sauerkraut. I teach you how to begin to eliminate toxins from the child's environment. I teach you how to embark on some practices that would help to eliminate toxins from the body of the child. So some of these things, you can actually pick them up and begin to make your child's situation much more bearable. So 3 things I have said here: the need for collaboration, the need to identify your own area and sticking to it, and the need for us parents to be able to teach ourselves, not just from fellow parents, but also when the professionals are talking. So that is my take on it.
Thank you, Ijoma. And when we started the session, I told you that all of these issues, as we start to speak about them, you will realize how interconnected they are, and that it's difficult to talk about one thing without talking on another thing, because as it's almost like it's layered like an onion. You peel and then you find, and then you peel and then you find. And so at this point, can I please ask all speakers or everyone who has spoken today to drop their contact details in the comment section, so that people can reach out to you, please, very kindly. And that's also because we're out of time, and taking as many questions as I had promised at the start won't be as possible. But please, if you don't mind, can people email you directly with their questions from this seminar, so that you can so that you can answer them? And so I'd asked Daisy to stay back. Daisy, this is the point where I need you. You know, we've spoken about all of these things today. It's important to collaborate. It's important to do this. It's important to do that. Someone has just asked the question, and I'm going to link this question to another question that I had for you when you spoke. And that is, look, what happens when people cannot afford this early intervention? We have said early intervention is good, it's this, it's beneficial, all of that. What happens when people cannot afford it? And this multidisciplinary approach, how do we take that down to schools that charge, 50,000 naira per term, per child? How do we take this down? The money barely even covers their own cost of operating. Do we then say they should turn back these children simply because they don't have? How do we manage this? Daisy, over to you. And please just take about 3 minutes. I beg you. I know it's a big question, but please.
Thank you. I'll try my best, Basira, and thank you so much. It's several questions, and it has several ways to look at it. First and foremost, parents' education. We need to train parents. They need to, I mean, I may be biased because I'm a parent myself. And one of the reasons I became a professional, I'm working on my third master's, and people think I'm crazy, but it has to be done, basically. And if once parents are educated and they're trained, they understand what it is, it's easier. Your work becomes easier. They have the skills, the prerequisite skills. They know what to do when you are not, because you're not going to be a part of that child's life forever. So it's important that we educate our parents, we train them, and they understand. The more educated they are, the more they begin to know the differences among the professionals. So for a lot of them, it's about my child has to talk. For a lot of them, it's a medical disorder. And because they think it's a medical disorder, they are looking for cures. They're looking for a lot of them, it's a spiritual thing. So they are looking for, I remember some years ago, a parent took her son out of the school for a couple of weeks, and we kept calling. And when the child came back, he came with incisions and all of that, because they had taken him to a place where they had beaten the hell out of him and giving him incisions. And he came back, looking all different and all of that. So we have, these are the things, these are the realities on the field. We need to be able to look beyond cash. It's not easy. I just got a recent increase in one of my schools that is on a rented property, and the increase is almost 50%. I have to pay it, and somehow that money has to come from somewhere, and somehow it has to go back to the students. It has to go back to the parents one way or the other. I know it's difficult for us to remain professional when we're thinking about how to even keep the organizations afloat. Nevertheless, ethics must guide us at all times. Ethics must guide us at all. And that's why it's important that we are trained. Thank God that within Nigeria, we're beginning to have things put in place, little by little. We have the Association for Behavior Analysts in Nigeria, ABAN. We have coming up soon, and I'm going to discuss this with Lola and a few of you soon. We have NISBEC, and I'm so excited that that's coming up. That's the National Institute for Behavior Education and Care Professionals. So we're going to have a place where we all will converge, and then we all will share our expertise. We all will share what we know and what we can do. And then we begin to separate the wheat from the chaff, the goats from the sheep, and know who is really a professional and who is just merely interested in professionalism. There's a difference between being a professional and being interested in the profession. They're two different things, and we need to be able to know that. I also want you say that when we talk about finance, parents may not be able to afford it. The masquerade you don't know always appears so big. You know, when you don't know something, it appears so, so large. You know, the day I saw a lion live, the first question I asked was that, so why is it the king of the jungle? Because I had seen quite a lot of other animals. The elephant should be, So what you don't know, all this appears so big and all of that. That's why we need to be able to build on that collaboration as much as is possible, collaborative practice. If I pick up my phone and I call, who is here now? Let's say I call Lola and I say, Lola, I've got this parent in front of me and this. Lola gives me tips that I pass on to the parent. The parent hasn't paid a dime, but I have collaborated with someone else. So it's very important. Then there's also the need for parents to be linked up with other parents. Support groups. Because when they're in the support groups, they begin to know that they are not alone. And then the denial begins to fade away. I run the Warrior Mom support group, and we have close to 700 or more parents of scattered all over Nigeria. And on that group, I am just a parent. I don't talk about Pleasant Places school, or whether I run a therapy center, or whether I have a training academy. No, that doesn't matter. I won't come on Lola's platform and talk about all the things I do, because we are here to run right now. This is Lola's idea. We are running with it. When these people come to us, put them at that place now where they are able to assess, give them referrals to 5-6 persons and say, this person does this person, not, oh, go and meet my friend. That's the beginning of our downfall as professionals. Once the person is your friend, whether the person is doing right practice or ethical practice or not, we are referring, to this person. So it's very important that we begin to understand what is ethics, what is professionalism, the role of parents, and how to help and equip parents. Thank you so much for your time.
Thank you. Okay, so this is what we're going to do.
I have been raising my hand since the
beginning. I know. Honestly, I have your name here to say something. So this is what we are going to do. Because we are out of time, there are 3 announcements I'm going to make. Number 1, certificate of attendance. If you want a certificate of attendance for this event, send an email to training.cacademy@gmail.com. The email will be in the chat section. Number 2, Stella, you have sent a question specifically for Adelola. Adelola, are you happy for Stella to email you directly with that question? Please.
Yes, that's fine. That's fine. Let me.
Okay, so Stella, you're able to email Adelola directly with this question. If you have sent me any other question and perchance I have missed it out, please feel free to email the speaker that you want to answer that question. And if it is not to any speaker, email C.A.D.E.T Academy with your question and they will respond to you. Now, Damilola, to you. Also, I'm sorry, I know you did say you wanted to say something, so this is what you can do. Can you please add it as an addendum? You know you're going to share your slides. Can you please add what you're about to tell us as an addendum? So, because of vocational study, and I know that if you add it as an addendum, it probably won't be rushed. It could be a voice note, it could be anything. Please add it as an addendum so that C.A.D.E.T can package all of these things. If you guys can get, if you have anything extra to add or, tips to share with the participants, just email them to C.A.D.E.T today. So that when C.A.D.E.T is emailing the participants, they can package all of these things together as, accessories, resources that parents and participants can use. So that way we don't lose out simply because we're running out of time. Thank you, everyone. Thank you. Daisy, I'm still coming back to you. I didn't know you run Warrior Moms, so I need you. I'm coming back to you separately. But thank you, everyone, for coming. I have had an absolutely fantastic time listening to everyone today. And I hope that we can have more of these conversations. But please take this away. It's not enough for us to listen to all of these things from UK and US and, all of these fancy names. We have to bring it home. Our reality is our reality, and we have to find a way to make these things work, not at the expense of the child or the parents or even the teachers. Thank you, everyone, and I'm handing over to you, Lola, 1320.
Wow. Oh, my God. This has been an awesome experience. I think, Lola, thank you for what you said to me. You said something that, she said, Lola, I'm always looking forward to C.A.D.E.T Academy trainings and webinars because it's always well thought out. And I don't want to take all the credit. I don't want C.A.D.E.T Academy to take all the credit. I want to say thank you to everyone. We thought of each and every speaker. And we thought about what we wanted to speak to our participants. And I want to give you, really, I told my heart to everyone because you actually spoke what our intentions, what the intention, the core of this webinar. So thank you to every speaker. We deliberately wanted collaboration. Now that's why we put that as a topic. So look out for more collaborative consultation and the partnership from C.A.D.E.T with every one of us here. Of course, we are going to be having our summer camp in August. Almost everyone is going to speak because we know there's a lot we need to do and we need to keep talking. At the beginning, I said, let's keep burn, let it burn until there's a change. Our purpose should be about the child in question. What is the next thing for this child? How do we move this child forward? I want to appreciate everyone from the depth of my heart. Thank you so. Daisy, Damilola, Ijoma, every one of you, I truly thank you for bringing your A game to this webinar. Thank you for speaking your truth. Thank you for all that you've done. Basirat, my sister, any day, anytime. I knew I could count on you to deliver. Thank you so very much for this. Every one of you, I appreciate you. So real quick, during the course of the announcement, we talked about the C.A.D.E.T Academy Inclusive School. One of the reasons we thought we decided to, this is coming up is because we realized that despite the fact that we operate an early intervention center, most times, and we're qualified to work with children from K through 12, most times these kids, we send them to schools and they come back to us. So at the C.A.D.E.T Academy, we have children who are getting, they need to be able to follow the ideal curriculum for primary 1, 2, 3, and 4, but they send them to us due to the fact of this inclusive education challenges too. And then we're doing this for them. So this is something that we had always thought of. And of course, we're going to reach out a lot of professionals on this webinar today, and they're going to be supporting us in executing this. Secondly, we also know that trainings are very important. There's a depth of trainings in the space, really. Topics like collaboration, like we're talking about today, and every other topic. We'll be bringing out such topics and we're collaborating with a lot of professionals in this webinar space to ensure that we put that in place and we can help people to grow professionally. Now, yes, and yes, and yes, don't forget, almost everyone here is going to speak at the Inclusive Global Camp that we're having in August. So get ready and bring on your A game. How do I thank you? I appreciate you. All this has been worthwhile for me. I don't know what any other person has to say, but I have learned. And I'm so glad we made this happen. So once again, happy Autism Awareness Month, Autism Acceptance Month, and all that we have done. So please and please don't forget that to leave your email addresses here, your contact addresses here. And oh wow, happy birthday, Ijoma. Can we all just take a minute to sing the song for Ijoma? I know our time is fast. 1, 2, go. Unmute yourself.
Happy birthday to you. Happy birthday to you. Happy birthday, Ijoma. Happy birthday to you.
We love you for your jolly good fellow indeed. Ijoma, you're such a blessing to this space, and we appreciate you, and we appreciate every one of you. If you have not dropped your email address and your contact, the whole idea is we want people to network to you so that they can meet the appropriate people in the field to help them meet their needs. Thank you all. I appreciate you. I love you. You've all made my day, and I look forward to seeing you in August. Have a blessed afternoon. Bye, everyone.
Please use the hashtag, tweet about the event, share it on Instagram,
Absolutely.
share the
Please
pictures.
do.
Tell everyone about what you've learned.
Thank you. Yes. Please go ahead and do that. Tag me. You know I'm going to blow it. Thank you, everyone. Thank you. Well, bye.
Bye.
Bye. Bye. Thank you.
Thank you, Lola. Well done.
Thanks, Lola.
And thanks,
Thank you,
Basira.
everyone.
We'll talk.
Thank
Bye.
you. Thank you.
Thank you so much.
Thank you.
All right, thank you, Lola. Enjoy.